Good morning. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Friday, May 30th, 2025. The time is 9 a.m. We are in room 123 of the John A. Wilson Building. This is a hybrid hearing where we'll be hearing from witnesses both in person as well as on the Zoom internet platform. This hearing will broadcast live on cable channel 13 as well as on my YouTube page at CMC Henderson. I'm calling to order this meeting of the committee for part 1 of 2 for the oversight hearings for the proposed FY26 budget for the Department of Behavioral Health. We will only hear from public witnesses today. Dr. Barbara Bazaran, the director of the department, will appear before the committee on Monday, June 2nd at 10 a.m. Dr. Bazaran and her team are watching and listening, and I'm sure they will try to respond to the concerns that are raised. The Department of Behavioral Health, also referred to as DBH, provides prevention, intervention, and treatment services and supports for children, youth, and adults with mental and/or substance abuse disorders, including emergency psychiatric care and community-based outpatient and residential services. DBH serves eligible adults, children, and youth and their families through a network of community-based providers and government services. DBH manages the district's school-based behavioral health program and operates St. Elizabeth's Hospital, the district's inpatient psychiatric facility. The Department of Behavioral Health performs vital and challenging work, serving district residents with the belief in their ability to recover from mental and substance abuse disorders, leading fulfilling and healthy, successful lives. I don't see any of my colleagues here. There are a lot of other hearings today, so they might be popping in and out, but we'll get to them when we get to them. We'll go to the first panel of witnesses. Before we get started, I just want to review the testimony guidelines for folks. We have a lot of public witnesses today, both in person and virtually, so everyone will have 3 minutes to speak. We have a clock that will begin to count down when you start. So because of the list of robust number of witnesses, I am going to give you a nudge to stay in your time. And it is not because I don't want to hear what you have to say, but it is because I do want to hear from everyone today. I'm going to call the first panel of witnesses. Rachel White, Deputy Director of Advocacy for DC Action. Robert Vincent Brannum, who's the Chairman of the Ward 5 Leadership Council and Public Safety Committee. Leah Castlas from Children's Law Center, and I don't see, oh, nope, there's Betty Gentile from Some Inc. See, the folks who've been to these hearings before know that we are on time. On time. No problem. All right. All right, Mr. Brannum, you're next, so I'll let you get seated. All right, when you're ready.
Good morning, Madam Chair. I have a prepared statement that I will submit to the committee. I need to stop.
No, go ahead.
Okay. To the committee, but I want to start by addressing 2 issues regarding the Department of Behavioral Health. One is that I want to commend the Department of Behavioral Health for the support of the DC carelink.org website link that permits and allows district residents to get information and make requests for services across the city to the website, through a web link. And I think that's a valuable tool, web link tool, that should be encouraged. I would also commend to the committee to support the creation of the Office of Men's Health that will help work with and get information on providing men, particularly Black men, with information regarding how to keep themselves healthy and survive. I'm part of an organization. It's called the Million Man Vote organization, and that's one of our planks. And I do want to take this personal time to express my blessings to two of my good friends who are under medical care. That's Mr. Ambrose Lane and Mr. Pierpont Mobley, the two valiant men in the District of Columbia who I'm praying will move forward in their health. And finally, I want to say to all my fellow Washingtonians that the budget dilemma that the district is in is not because of the actions from you as the chair or this address, the Wilson Building, but from Pennsylvania Avenue, 1600 and Capitol Hill. President Donald Trump and Speaker Mike Johnson don't care about the District of Columbia, and they're the ones that have caused much of the concerns and trauma that's impacting how the district moves forward in the creation and extension of his budget. And I support RFK Stadium development. Thank you.
Okay. Ms. Castlas.
Good morning, Chairperson Henderson. My name is Leah Castlas. I'm a senior policy attorney at Children's Law Center and the co-chair of the Strengthening Families Coalition. The mayor's proposed budget for DBH includes a $3.3 million cut to the school-based behavioral health expansion program. This $3.3 million cut appears to be a combination of a cut to the overall programming line and DBH shifting funds internally. Based on the information available in the budget books, we are not able to determine how DBH is allocating the $25.4 million it has dedicated to towards school-based behavioral health between the expansion program, DBH clinicians, DBH staff, evaluation, and other budget lines. Therefore, we ask this committee to ask DBH to provide a detailed breakdown of the budget for school-based behavioral health programming. During difficult and uncertain times, it is alarming to see behavioral health services cut when we hear directly from DBH about the growing number of students, parents, and teachers reaching out for support. It is also concerning that every year since FY22, the budget for school-based behavioral health has essentially been cut despite an outcry for adequate, accessible, and high-quality behavioral health services in the district. Ultimately, we want to make sure that the expansion program is adequately funded to support the goal that students at all schools have access to all three tiers of services. During this current budget crisis, that may not be achievable, but we do believe that adequate funding should remain a goal for the district and this committee. To this end, we ask the committee to ensure that the FY26 budget does not redirect funding from the expansion program to other DBH priorities. Further, in the face of this continued whittling away of the expansion funding and therefore grant amounts, we believe action from this committee is needed to ensure progress isn't lost. To stabilize schools that already have CBO clinicians in place, we ask this committee to establish a minimum grant amount of $129,000. Given the funding currently allocated to the expansion in the mayor's proposed budget, $129,000 grants would fund all 101 schools that have CBO clinicians hired. With funds remaining, it can fund the OSCE analyst position, school-based behavioral health coordinator stipend, and the dashboard, and still have money left over to fund 14 additional schools. Raising the minimum grant amount does not require DBH to increase funding. Setting a higher grant minimum recognizes that there are significant billing issues that plague the funding model, including cumbersome billing procedures, insufficient reimbursement rates, and fluctuating grants. Without a minimum grant amount, CBOs will have to make the decision to either continue to operate at a loss or leave the program. And while the expansion will not at this time be able to place a clinician in every school, it will be able to stabilize clinicians that are already in place and set the program up for success to increase the number of clinicians in schools in the future. I appreciate the opportunity to testify and welcome any questions the committee may have.
Thank you. Ms. Gentle.
Greetings, Chairperson Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Betty Gentle, and I serve as the Senior Director of Advocacy and Public Policy at SUM Incorporated, a nonprofit organization committed to breaking cycles of homelessness and poverty in the district. SUM is also a DBH certified provider offering comprehensive behavioral health services, including mental health and SUD treatment, integrated with transitional and permanent affordable housing through our whole person care model. Together with DBH, we offer the stability and support people need to begin healing and move forward with dignity. Some is a proud member of the DC Behavioral Health Association and the DC SUD Provider Coalition, networks of providers who believe all DC residents deserve compassionate, high-quality care. Mayor Bowser has framed this year's budget as one designed for DC's future. However, for many low-income residents and those experiencing homelessness, this future feels increasingly uncertain, especially as it relates to the strength and sustainability of our public healthcare system. With an opaque DBH budget and proposed changes to Medicaid and the DC Healthcare Alliance still not fully explained, we remain concerned about whether this budget prepares us for future federal cuts or if it weakens our behavioral health infrastructure in advance of them. We respectfully ask this committee and the council to seek clarity and insist on transparency around how local service reductions may impact access to care for the tens of thousands of residents who depend on DBH-funded services through community-based providers like SUM. As some, we believe housing is healthcare and that transitional housing, particularly when linked to behavioral health treatment, should be recognized and funded as essential infrastructure in addressing DC's opioid crisis and broader behavioral health challenges. We were discouraged to see that despite clear calls for more housing from both providers and residents at the recent public roundtable on the opioid crisis, this proposed budget reduces funding for behavioral health housing and wraparound supports. According to the 2025 point-in-time count, of the 3,782 unaccompanied individuals experiencing homelessness in the district, nearly 1,000 reported mental illness, more than 500 reported a substance use history, and over 300 reported a dual diagnosis. These data underscore the urgent need for targeted supportive housing solutions that meet people where they are, especially in recovery. SUM is gratefully currently receiving a SOAR grant and a grant through the Office of the Opioid Abatement Commission to support our transitional housing work. These funds have been vital, but they are one-time resources. To truly meet the ongoing needs of residents and avoid further fragmentation of services, the district must establish sustained recurring investments in behavioral health housing and treatment services in the FY26 budget and beyond. Last, to maximize the impact of every available dollar, we urge DBH to prioritize the timely disbursement of grant funds and provider payments. Delays not only jeopardize our ability to maintain staffing levels and deliver consistent care, but they also hinder long-term planning and operational stability. We also encourage DBH to reduce administrative burdens where possible, or at minimum to offer greater flexibility and proactive communication to ease provider strain. These steps are not just technical adjustments, they are essential for ensuring that care delivery remains centered on the needs of our clients, not mired in bureaucratic complexity. As we brace for several years of tighter budgets and shifting federal priorities, including potential changes that may conflict with DC's health equity goals, it is more important than ever that DBH providers and the council act as true partners. Just as we are stood together to oppose harmful Medicaid cuts at the federal level, we must continue to stand together to protect and expand access to behavioral health care for all DC residents. Thank you.
Thank you. Ms. White.
Yes, good morning, Chairperson Henderson and members of the Committee on Health. My name is Rachel White, and I serve as the Deputy Director of Youth Advocacy at DC Action. I want to begin by thanking the committee for the opportunity to speak today. As you continue to weigh difficult budget decisions, I urge you to protect, not weaken, the behavioral health infrastructure that young people rely on. We recognize the fiscal constraints you're working within, and we are not here today to request an enhancement. However, we are here to stress that even in tight times, we cannot afford to cut critical services that are already stretched thin. In our 2025 State of Youth Homelessness Report in the District of Columbia, we highlight alarming gaps in the behavioral health system and access for youth. Many are navigating housing, instability, trauma, and disconnection from stable adults. They are overwhelmingly Black and Brown, LGBTQ+, immigrants, parenting youth. Their needs are urgent, and the barriers they face are structural. We know that young people experiencing homelessness are significantly more likely to suffer from depression, anxiety, PTSD, and suicidal ideation. Yet accessing help is often difficult or delayed, especially when behavioral health services are siloed from the places where youth already show up, like drop-in centers, shelters, and schools. This is why we continue to advocate for co-located and embedded behavioral health supports across youth-serving settings and for intentional investments in diverse workforce that reflects the language, culture, and lived experience of the youth that it serves. Emerging findings from our ongoing citywide youth mental health needs assessment reinforce these trends. They're not just struggling with emotional help, but with basic needs such as housing, food, safety, stability. They're not finding providers who look like them, speak their language, or understand their identities. And they are tired of being funneled into services that feel rushed, disconnected, or designed without their input. The most consistent message is youth are asking for mental health supports that are embedded where they already go. They need bilingual, LGBTQ+ affirming, culturally grounded professionals who can meet them where they are. That's why the proposed cuts to the school-based behavioral health system, $2.3 million, crisis services, $1.2 million, and the community response team of $798,000 are so alarming. While we don't know whether these are structural cuts or reflect unspent funds, the impact on youth will be real, especially for those who are already facing the greatest barriers to care. We urge you to ask the Department of Behavioral Health the following questions. Are these reductions due to staffing vacancies, underspending, or intentional service reductions? How will these cuts affect youth experiencing homelessness, trauma, and system involvement, particularly Black, Brown, LGBTQ plus youth? How is DBH evaluating the effectiveness of these programs, and will these evaluations be publicly available? Lastly, I want to name a critical data challenge. The point-in-time count often cited in these hearings continues to vastly undercount youth experiencing homelessness. The PIT is a single-night snapshot that fails to capture the thousands of young people cycling through unstable housing or staying temporarily with others. We cannot base budget decisions on flawed data that does not reflect the full scope of the need. Now is not the time to retreat. Thank you for your leadership, and I welcome any questions.
Thank you. Thank you for this panel of witnesses for your testimony. Ashley, you just put me on 5. Thank you. Ms. White, you listed a bunch of really good questions for which we'll ask as well. And I think, Ms. Castlas and Ms. Gentile, you've also asked some questions that I feel like are good. This is the sort of trouble of, I think we've had the budget for less than 5 days. So there are things that we need to get down to the bottom of as well. But there are a couple of things. So first, Ms. Gentile, you talked a little bit about housing and the need for supports on transitional housing. When we talked to the AFO, which is the Agency Fiscal Officer, around the reduction around housing and residential support, we were told that the majority of that reduction came from unused vouchers. A lot of people don't realize that we have several agencies outside of DHS or DHCD, rather, that have vouchers on their own. DBH has vouchers. The Office of LGBTQ Affairs has vouchers, Office of Veterans Affairs, et cetera. So the reduction that they're saying they're using here is from realizing savings from vouchers that had gone unspent. It sounds though what you are referring to in terms of transitional housing is different than vouchers, and perhaps are we investing in not the wrong thing, but should we be, instead of cutting it, redirecting it to a deeper need?
So it's interesting that they would say that they probably are in use, but I wonder, why that is. Because I know that folks that I've talked to, like in our community resources, come to the dining hall, they know about all the different ways to go about trying to get a voucher. And I don't know to say if that's the improper way, but I know when we've talked a lot about transitional housing recently, and during the opioid public roundtable, is when people are transitioning out of treatment, and especially for our folks, I think 95% of the people that come to our residential treatment program are unhoused, and that was the reason we even started developing affordable housing, because we started residential treatment first. And people were like, I don't have anywhere to go. In the places that I have to go, it's going to be extremely difficult for me to maintain my recovery. So I would say that definitely is important. And like I said, with the opioid abatement grants, I know several providers were able to get those grants and use them for transitional housing in that way, but that funding expires at the end of this fiscal year. But even thereafter with permanent housing, and thankfully with some, because of our continuum of housing, we are able to transition a lot of people into permanent housing, but that's not the same for everybody. So it's really the full continuum, as well as safe housing, even before going into treatment, because we were able to provide that until recently. And it would probably take people an average of 30 days to really stabilize before they even were ready to go into residential treatment. And so it's the full continuum. So even if those specific vouchers are going unused, their money should be dedicated to some type of housing in regard to treatment.
Thank you. Ms. Castlas, we've had lots of conversations about school-based behavioral health. What's interesting to me is that, at least on paper, it seems as though DBH is acknowledging that they have been unable to reach 100%, which is what we knew. But this sort of desire to keep doing the same thing and hoping for a different result. They call that the definition of insanity. Great. Mhm. So we definitely have some questions for DBH on that. It's good to hear from you all. I feel like a year ago, we started this conversation about how this program should look differently. And I don't feel like the agency is making any progress whatsoever, which now I have to do something different. So let me ask you this. Do you feel like DBH should continue to have the school-based behavioral health program, or should we move it to another agency?
So I've thought of a lot about this, and I think, I think your point is well taken, that we seem to be continuing to run circles. And so I think there are potential to move it to another agency. I would want to think a lot deeper about how that looks, because there is the clinician piece that DBH does have expertise in. And then there's the grants management piece that I think some other agencies have expertise in. And so the other piece I think we've really emphasized is, how do we become more collaborative? And I think that's across the district, right? With all our government agencies.
Yeah.
And so, DBH isn't the end all be all of this program. There are many other players in it that need to be more collaborative. And so how do we think through that transition and whatnot? So I think there's some opportunity though.
All right. Well, thank you all so much. Please make sure you upload your testimony for the record. We're going to go to the next panel of witnesses. Tracy German from Academy of Hope Public Charter School. Here, Kristen Yuing, from DC Appleseed. I see Kristen. Chad Jackson, who chairs the Opioid Abatement Committee. Justin Palmer, DC Hospital Association. We'll grab it. Ashley, if you could just, Thank you. Thank you, Justin. Okay, I don't see Tracy, so I have one more seat. Deborah Thomas, Nurses Association. Okay. Daryl Stewart, DC Nurses Association. Great. Okay, Kristen, when you're ready. Oh, turn your mic on. There you go.
Good morning. My name is Kristen Yuing, and I am Policy Counsel at DC Appleseed and co-chair of the Strengthening Families Coalition. I want to echo my fellow SFC co-chair Leah in our concern regarding the cuts to the school-based behavioral health expansion program and the need to establish a minimum grant amount. Setting a minimum grant of $129,000 ensures that CBOs can remain involved in the expansion program, and it acknowledges several critical challenges of the program. First, forthcoming federal Medicaid changes create unpredictability in revenues for CBOs. Since the program heavily depends on Medicaid reimbursements, the instability of Medicaid makes it vital to increase the grant to help counterbalance potential cuts and coverage changes. Second, the current billing system does not align with the financial requirements of the program. The billing process is complicated, costly, and inefficient. CBOs typically manage to collect only 30% of their billed amounts due to insurance challenges, including not being contracted with private insurers and low reimbursement rates. Also, our calculations indicate that CBOs need to bill around $33,000 per year to ensure economic viability, but are averaging roughly $13,000. This means CBOs must place an emphasis on one-on-one billable sessions with fewer opportunities to provide other levels of service in schools, such as prevention programming or drop-in hours. All levels of service are vital for a robust program, and the funding needs to allow clinicians to respond to student needs, not billing requirements. Third, many CBOs are experiencing financial losses with the program each year, with some reporting losses amounting to tens of thousands of dollars. Some CBOs have already had to leave the program due to this. Last, fluctuating grant amounts from year to year create uncertainty regarding funding, which can make it challenging for CBOs to budget as well as recruit and retain clinicians. If the grant amount remains flat, more CBOs will face a difficult choice: continue to operate a loss or withdraw from the program, leading to instability and coverage gaps for schools, students, and families. My colleague also mentioned other coalition budget requests, including a stipend of $1,500 for DC schools' school-based behavioral health coordinators, and funding a school-based behavioral health management analyst at OSSI. While these are technically OSSI budget requests, I would like to address them briefly. We know that robust data on schools Robust data on school-based behavioral health will help inform future budget allocations and policy decisions, enabling us to improve the program. We are incredibly grateful to Dr. Basran and her team at DBH for the significant work they did on the environmental scan to landscape school-based behavioral health offerings across schools. We believe the behavioral health coordinators can play a substantial role in collecting this data on an ongoing basis moving forward, and they deserve compensation for this currently unpaid role. Furthermore, an analyst at OSSI can collect and analyze data from across schools to build on the work DBH has already done and foster relationships among DBH, OSSI, schools, providers, and CBOs. We can stabilize the program by increasing grant amounts and maintaining ongoing partnership with current CBOs and clinicians, and then continue to build and strengthen data collection and analysis. Then we can make evidence-based decisions to improve this crucial service, ensuring we utilize the resources we have in the most effective and efficient ways possible to enhance behavioral health, attendance, and academic outcomes for DC students. Thank you, and I'm happy to answer questions.
Thank you. Mr. Jackson.
Councilperson Henderson, council members, staff, thank you for the opportunity to testify in front of the Health Committee. My name is Chad Jackson. I'm testifying as a citizen today of the District of Columbia. I'm also the chairman of the Opioid Abatement Advisory Commission. I have an expertise in substance use disorder, have a business in DC that serves people with substance use disorder, and I'm a person in long-term recovery. Today, I'd like to draw your attention to an opportunity for the DBH to save a little bit of money, which seems like there's a lot of places to put this. It's a rare opportunity to take a program that DBH is doing well, which is the naloxone distribution program, which I think is one of the best in the country, and something we should be very proud of. Some facts about this: DC has a contract with a provider to provide our Narcan branded naloxone to the city at a fixed cost. It's a pretty good cost, $33 per dose, which is 2 packages. The 2 nasal plungers in each package that's a dose. It's a 1-year contract that has 5 extendable options, so they can option it for 5 years. They're 2 years into that. They're getting ready to do their 3rd year. One of the things about naloxone, it's been used in hospitals since 1971 to reverse opioid and opiate overdoses. It's really designed for opiate overdoses, which is natural opioids. It's been used since 1971. The spray that we're using, the Narcan, is actually the device. The device is what had been patented, rather than the chemical. There's a generic available that starting 2 days from now, starting in June, has a 36-month, has been approved by the FDA for 36 months of shelf life, which is what we started this contract with Narcan, I believe. Narcan is now 48, but 36 months of shelf life, even though we know that it's available for longer. And this generic is available on the market for a 20% reduction of what we're currently paying, $27 per unit. The same units, the same way it's done. It's a generic. I think it's important to understand, with this, that Emergent, the provider of the Narcan, is not necessarily a good actor in the pharmaceutical field. None of these pharmaceutical companies are altruistic, but I think we have an opportunity to move to something that saves us money, provides the same efficiency, and gives us an opportunity to move that money into some other places. Thank you. I'm happy to answer questions.
Thank you. Mr. Palmer.
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Justin Palmer, and I'm the Vice President for Public Policy and External Affairs for the District of Columbia Hospital Association. I appreciate the opportunity to present testimony at the Department of Behavioral Health's FY26 Budget Oversight Hearing. As you're aware, DCHA is the unifying voice for districts, hospitals, and represents the interests of our members who provide care to residents from all 8 wards, to our neighbors in Maryland and Virginia, and patients from around the world. When it comes to the Department of Behavioral Health's FY26 budget, during this difficult financial plan, it is critical that the district continues to make the necessary investments to improve the behavioral health of our residents. This includes ensuring continued investments in school-based mental health services so we're able to meet the needs of our youngest residents and those of their providers. We must also continue addressing gaps in the services for adolescents and kids within the community. Residential services are not only needed for adults, but children as well. Finding ways to encourage investment, both from the government and private sector, to meet these needs is critically important. St. Elizabeth's Hospital continues to play an essential role for the district's behavioral health infrastructure. Continued investment in the hospital is key, as is exploring expansion of it to meet forensic needs as well as the communities. We are supportive of the enhancement of $9 million in overtime at St. Elizabeth's, and we urge the committee to ensure that the $2.4 million reduction in clinical medical services and $4.4 million in nursing services does not impact the facility's ability to care for patients. Any reduction in capacity because of staffing would cause even more ripples throughout the health system, since the hospital is frequently operating at capacity. During the budget process, we also need to be sure that the new proposed MHRS budget will be sufficient given other benefit changes being made. DCHA and our members believe that it is critical that there is sufficient funding to provide community service for all those that need them. Finally, I spoke earlier about the need for more residential community services. This has consistently been identified as a need by the DCHA's Behavioral Health Collaborative. We need to ensure that, make sure that we understand the impact of taking the funding for housing, residential support, and community continuity services below the FY23 funding levels will have on the ability of residents to access services. The work being done by Dr. Bazaran and her team is essential for the district, and we look forward to continuing working to support the department as they carry out their critical work. Thank you for allowing me to testify today, and I'm happy to answer any questions you may have.
Thank you, Justin. Mr. Stewart.
Good morning, Councilwoman Hendrickson and the members of the committee. I am Daryl Stewart. I'm the Vice President of the District of Columbia Nurses Association and a nurse practitioner at St. Elizabeth Hospital since October 2019. I hold an active license as a registered nurse as well in the District of Columbia. I appreciate the opportunity to advocate for our dedicated nurse practitioners, nurses, and behavioral health technicians at St. Elizabeth Hospital. They show extraordinary commitment to our patients, even in the face of escalating violence and lack of essential resources that cannot be ignored. The alarming 5-to-1 ratio of pretrial admissions from the District of Columbia Central Detention Facility compared to civil admissions from the general population is creating an explosive environment. This demographic, predominantly younger and male with criminal backgrounds, poses significant risk of safety, yet management has failed to address the corresponding rise in violence adequately. We have lost 6 security staff members due to budget cuts, and many hospital units lack protective barriers to ensure safety. Decisions affecting patient care and safety are being made by an administration devoid of frontline psychiatric nursing experience, which is unacceptable. I must emphasize the urgent and intolerable shortage of medical supplies and basic hygiene products affecting our patients. I frequently encounter situations where essential supplies are missing, which directly compromise the quality of care I can provide. The administration's mismanagement of inventory, combined with lack of necessary medical expertise, forces me to escalate requests for basic items frequently. For instance, I had a patient suffering from a stage 3 decubitus ulcer due to the hospital's inability to provide adequate dressings. I took it upon myself to order necessary hero protectors from Amazon, a shameful situation that should never occur in a hospital setting. Additionally, my diabetic patients are using outdated glucometers, producing inaccurate readings, while newer devices remain unusable due to neglect. A bariatric walker I requested took 4 months to arrive only after the patient had been discharged, and prescription eyeglasses often take 3 months or more to process, arriving well after patients have been discharged. Furthermore, the chronic shortage of personal hygiene products such as soap and toothpaste has forced staff to pay out of pocket to provide these essentials. So in conclusion, the cuts to security, the absence of protective barriers in all units, insufficient medical supplies, delayed medical services, and lack of basic hygiene products stem directly from budget mismanagement at St. Elizabeth Hospital. While I want to believe the DC Council has approved necessary funding, it is not reaching patient care and safety, and we demand transparency, and it is vital that nurse practitioners, nurses, and behavioral techs are included in the decision-making process with the current administration. So thank you for letting me testify, and I'll welcome any questions.
Thank you. Thank you to this panel of witnesses. Mr. Stewart, I want to start with you. I've been chair of the Committee on Health for, I guess this is my 3rd year now. And so this would be the 3rd budget that I'm dealing with in terms of health, but also oftentimes when I get to the St. Elizabeth budget, there are very few changes, very few enhancements. Some in the last couple of years, there have been enhancements for capital But very few enhancements in terms of personnel, supplies, services, et cetera. And when we ask questions in terms of testimony, they'll say, well, there was a period of time where St. Elizabeth's post-COVID had a smaller population. And so they were like, we're fine. And now in terms of your testimony, it sounds as though, and we know from the census, the patient census, that the numbers are going back up, but there aren't corresponding increases in funding to necessarily address some of those things. I want to ask, when, your testimony was very troubling for a variety of reasons. The outdated diabetic readers, prescription glasses that takes months to arrive.
Mhm.
What's the delay? It's a hospital. So I know I don't have those issues
Sure.
with MedStar or GW or Sibley. So
I
why
can-
does it take so long?
I can tell you, I don't know why it takes that long. I can give you my opinion of what I think is going on.
Okay.
I personally think there's just mismanagement of the funds because it makes no sense not to be able to have the funding for these items. I think one of the reasons I've heard about delay in eyeglasses is that vendors haven't gotten paid, so they don't deliver the eyeglasses. I know that's one thing that I've heard. I can't explain why it takes 10 years to get new glucometers, and then when we get them, the Wi-Fi system is still not up to par. We can't use them properly. I don't manage that. We've talked about it all the time in our meetings with administration. We meet with them monthly, but we keep getting the same answers. Delays that make no sense. But my feeling is that two things. There's maybe some mismanagement of the funds, and two, the people like myself, frontline workers, are just not included in the decision-making process of what is really needed to
Mhm.
really function. In terms of supplies, if you have a medical provider who knows the type of dressings that you should have, maybe he should be at the table to make those decisions about what you're purchasing instead of purchasing supplies that are not needed and then expire and don't get used.
But you all have a chief nursing officer or chief medical officer
Yes.
who would be at the table, no?
Yes. Yes.
In theory. Okay.
In theory, yes.
I'm happy to sort of, not happy to, I will follow up on some of these things. I mean, the budget proposed does and provide some additional funding for increase in overtime. Let's see. And supporting victims of traumatic brain injury. And then also some additional funding for clinical administrative services, but there are reductions. Clinical medical services, 2.4 million and 4 FTEs. A cut to housekeeping services, a cut to nursing services, a cut to nutrition services.
What could also be happening is that maybe money is being taken from here, borrowed from here to pay Peter to pay Paul.
Robin, Peter,
We
pay
have a
Paul.
lot of
Mhm.
people that go to outside hospitals for emergency services, for outpatient evaluations, and they bill for that. So I really don't know. There's not enough transparency around that budget process about how how money is spent.
Okay.
I do think you provide the funding, but I just don't know how, it doesn't seem to be allocated properly. And yes, we do have these people in administration, but we're not at the table to really see what extra is going on. We're not included. It's
Okay.
just a round table of the CEO and the CNE and whoever, and we don't know what's really going on. So as a medical provider on the front line, I know what's going on. I know what's not there for the individual in care. So I have to advocate quite often with the CFO as well about these issues. Usually it's a reactionary response rather than a proactive response.
Okay. All right. I'll follow up with DBH on some of
Thank
these
you.
issues. We spent a little bit more time on St. Elizabeth's. I want to thank the rest of you for your testimony as well. You brought up some very issues that we've sort of already discussed, but then issues to go further. Whether or not we should make some changes on contracting and whatnot. So thank you all so much for being here.
Thank you.
Okay. We're gonna go to our next panel of witnesses. Nancy Boyd, Gerald Bay Young, Lakia Richardson, Xavier John, Nicole Chaffa. Apologies if I said that incorrectly. How many seats do I have? 1, 2, 3. Exodus Nuziru. Okay. Amarachi Got it. Okay. All right, Ms. Boyd, when you're ready.
Good morning, Councilwoman Henderson. Thank you for having us here. I'm Nancy Boyd. I'm the president of DCNA and nurse educator at St. Elizabeth's Hospital. I'm representing the courageous nurses and techs at St. Elizabeth's Hospital. We are here today to address a pressing issue that has reached an intolerable level and the frequent violence against our staff. Currently, we are experiencing an average of 37 physical assaults each month, more than 1 assault every single day on our staff or the individuals in our care. This relentless violence has taken a toll, leaving many of us with symptoms of PTSD. However, we find ourselves in an environment where our safety is not given the priority it deserves. Since I joined the union in 2013, despite the alarming 98% increase in forensic individuals at our facility, there has been a lack of substantial action to address this escalating violence. The psychiatric staff, leadership, and executive leadership on multiple units and multiple levels are not effectively collaborating with us, the union, leaving us to manage chaos on our own. We are often thrown into perilous situations, forced to manage aggressive and unpredictable episodes involving individuals who are unmedicated. When nurses are injured, instead of receiving support, we face blame, comments like, "This is what you signed up for," only further normalize the violence we encounter. This to us is unacceptable. We are at a critical juncture where immediate action is non-negotiable. Here's what we demand to ensure our safety and the integrity of our environment. We need increased security presence. We would like a minimum of officers to be available in every unit 24/7. This is essential for our safety. Installation of jail phones, the phones that were promised, that the funds were allocated for, that have never been installed on any of our units. Enhanced communication tools such as walkie-talkies, reinforced nursing stations to be built up on every unit to the ceiling. A lot of our nursing stations are one way in and one way out. So essentially, we're trapped if anything occurs. Stronger entry and exit doors, doors that are reinforced, that are installed so that individuals in cares don't have the ability to kick and knock the doors out and get to us and attack us. Comprehensive safety training programs, adopting a new and practical approach to physical safety training. Additionally, we must address the severe mismanagement of funds. Programs, services, and essential supplies are being abruptly cut mid-year, compromising our ability to deliver safe and effective care. As a union leader, we are tirelessly advocating for the safety of our staff. We hope that administration takes our concerns seriously and implement these crucial changes immediately. Thank you for letting me speak.
Thank you. Gerald?
Hi, good morning, Ms. Anderson and the committee. My name is Gerald Bay Young. I'm a charge nurse transferring from 2TR, one of our units, to 1G. I have 30 years experience in mental health as a psychiatry RN with children, adolescents, and adults. I've worked in hospitals in the metropolitan area, including PIW, Children's National Medical Center. Most of my experiences is from hospitals in the Washington, D.C., such as Riverside Hospital, Lawton Jail, D.C. Jail, and Howard University Hospital, as well as mental health institutions in Maryland, such as Annapolis Jail and Adventist Hospital. We need to address critical safety concerns at St. Elizabeth Hospital. The current lack of safety protocols and support for both staff and individuals in care is unacceptable. We are dealing with individuals in care who exhibit dangerous behaviors, including those who are actively malingering and those who express desire to return to jail. I have witnessed firsthand the grave dangers posed by some individuals in care, including individuals in care charged with murder and those suffering from severe psychosis. These cases demand urgent intervention through emergency medication, restraints, and seclusion. We also encounter individuals with borderline personality disorders who exhibit psychotic features. These are not just challenging cases, they are dangerous individuals. If the DC, DOC, and DOJ struggle to manage severely ill individuals within the jail system, we must seriously question how St. Elizabeth and stroke DBH, without proper equipment and support, is expected us to do so. The contrast is stark. These DOC employees are armed and trained to handle high-risk offenders. Yet our staff face similar challenges without adequate resources. It is unacceptable that our staff face suspension and termination for not managing these situations correctly. Then, with no clear guidance exists for handling dangerous or malingering patients. With our population increasing, compromising of 98% forensic cases, it is time for the DC government to reassess our pay structure, retirement benefits, and most importantly, our safety. Staff at St. Elizabeth Hospital are human beings. We live outside of work. We come from various backgrounds, just like our individuals in care. It is paramount that they receive the utmost respect and best care possible. Basic resources such as glucometer strips, functioning equipment should not be an issue for this facility as of St. Elizabeth's structure. Management has repeatedly promised improvements that are yet to be met. The DC Council of Health must urgently address severely budgetary issues that directly impact the safety and efficacy of St. Elizabeth Hospital. Key areas of concern include staffing ratios. The current budget does not allocate staffing funds to ensure adequate staffing ratios across units. We require 24/7 security staff to be available at every unit and throughout the hospital. Currently, we are functioning in a shortage. Hazardous pay for workplace violence. These are urgent issues that need to be addressed. The risk workplace violence faces by healthcare staff. Implementing hazardous pay for employees in high-risk environment is essential to acknowledge their challenges and ensure safety, well-being in the workplace. Resources for managing violent behaviors. The budget should prioritize funding for necessary equipment and resources for managing aggressive individuals in care. This includes stronger doors, necessitation built in the ceiling, and the physical management program infrastructure.
Ms. Ring, you're over your time. I'm giving you a little grace, but you have other colleagues who want to speak.
Sure.
So just hang on and I'll ask some follow-up questions.
Thank you.
Okay. Lakia is not here.
Yes.
And Xavier is not here. Nicole? Okay.
Good morning, Ms. Anderson. My name is Nicole Chaffa. I am a registered nurse at St. Elizabeth Hospital. I'm a DC resident. I have been a DC resident all my life in America. I am a resident of Ward 4. And this is the second time I assist and participate to a hearing. I am here because my unit has become the punching ball of the staff, the staff on the unit. We have passed from the COVID quarantine unit to the acute, very acute unit in the facility. Our census is 7, but currently we host only 2 patients. Why? Because there is an individual in care that we are unable to control despite all the effort, all the policy, all the procedure that we have been trained to. We arrived to a point that we are hiding behind the nursing station. We have no safety exit to be able to run away from the patient. We have 20 staff in total. 7 has been gravely injured, 3 near missed, and other has not still resumed to work. We find out that constantly we are asked to manage. We are living in the richest country in the world, and we are deemed, according to our policy, our health, to provide the highest care we're supposed to. But unfortunately, we are not provided the means to do so. And we are constantly getting injured, and nobody is thinking about uphold our safety. We are requesting here that the review of all the units, the setting of all the units should be reviewed in adequacy with the population that we are receiving. Secondly, they're supposed to allocate permanent security that can promptly intervene when there is a situation on the unit. Thirdly, we are requesting for specific training with regard to the specific care. If we are talking about patient-centered, the training should not be a global training for the whole hospital. When you are facing a specific case that is challenging on a unit that is acute, that is assigned to those type of patients, we're supposed to receive specific training, often to be able to handle the patient and to be able to provide a better outcome. We need the fund because everything is the power of the pocket. If we are not allocated the fund, our institution is unable to provide adequate staffing, adequate security, adequate environment, and protection of the staffing. Thank you, Mr. Anderson,
Thank
for
you.
listening to me.
Thank you. Ms. Obu. Yes. No, say it for me.
Amarachi.
Amarachi.
Good morning. Good morning, Mrs. Anderson, everybody. My name is Amarachi Oboki. I'm a registered nurse on all the female forensic units. We are gathered here to address a harsh reality, physical violence against healthcare workers that has reached a staggering level. This is not a mere statistic, but it has morphed into crises that demand immediate action and attention. Every nurses in tech at St. Elizabeth Hospital dedicate their lives in caring for patients, ensuring their well-being and promoting their health. Yet it amends our noble effort to face threats and acts of violence, putting our safety at risk, whether it's violent, physical, attraction, or intimidation. These incidents are not isolated. It happens often, and it erodes our morals and affects our quality of care that we provide. Imagine coming to work each day knowing that you're facing hostility and aggression while trying to fulfill your duties. Its environment draining and demoralizing our lives. Unfortunately, many of our healthcare workers, this is what we face on a daily basis. But we continue to show up in a daily basis in order to commit, because we are committed to our patients. Yet, it affects our mental and physical health. What has compounded our issue is that the growing silence among us. Many of our co-workers are fearful to speak out because of fear of retaliation, because of fear of being labeled, complained, or dismissed. But this culture must change. Change has to come. We must foster an environment where nurses will feel empowered to be able to express their needs without being fearful of what retaliation might be. We urge for effective training that will equip our healthcare personnel to be able to de-escalate issues before they become violent. And we ask for conflict resolution and techniques that are necessary to support healthcare workers, and also to prioritize the safety of our patients and staff members as well. However, we advocate the legislature to hold these offenders accountable, the violence against healthcare. They should be treated as well, not accepting that it's okay for us to be violated. And they tell us it's okay to be violated. We are human beings as well. Thank you.
Thank you. Thank you to all of you for taking time to come and tell us, because like I said, I've been to St. Elizabeth's Hospital, done the tour. What I see is a little bit different than what you see on a day-to-day basis. And therefore, the only way that I know any of this is if someone says something. Ms. Boyd, I want to start with you because you're the president of the association. And this has kind of been mentioned a couple of times around the forensic population outpacing anyone else who is admitted to the hospital. What are we talking about percentage-wise?
98% is what we were told at our last assaults meeting by our CEO, Mr. Chastain. He said 98% of our population has now become forensic, opposed to when I started, where it's a 60-40 range, where 40% were from the community and 60% were from the jail.
I mean, that's concerning it for a variety of reasons, because if someone from the community is in a non-forensic case, but is in need of care and services, you can't get in.
Correct. There's a waiting list at the hospitals.
Okay. But also when you go to 98% forensic, I'm a little surprised that the security didn't follow, or the changes in protocol and security did not follow.
No.
A number of you talked about the need for having security on each unit.
Right.
Is that not currently, what is the current practice?
We only have 7 security per shift. So that's only
for the whole
for
hospital.
the entire hospital.
for 98% forensic.
Correct. Mhm.
Okay.
Yeah.
No, I'm just.
And they have to monitor other things. So they also have to monitor the grounds. They have to stand by things that are broken so that all that they get allocated all over at different places and not necessarily on any unit.
Okay.
It generates overtime when you have to ask them to be able to be on these units with these extra acuity.
I know, but in terms of your case, Mr. Chaffa, you're speaking about a patient who is so violent that you can't even put the number of people who could be on your unit on your unit.
Yeah.
We have 7 beds.
If you just use your mic. Press
Oh,
the button.
press the
Yeah,
button.
yeah, it's okay.
We have, our census is 7 bed. And the patient was so violent that the administration decided to remove all the other patients from the unit to protect them, but not to protect us.
So there are two people.
There are two, currently there are 3 because we had one admission and he's going to go to his assigned unit to this weekend. We have 2 patients on the unit and the second patient refused to move because she's used to the unit and also because all the other unit where she has been were burned out to the point that they were rotating the patient for 45 days on each unit and she landed to us and she has been with us for practically 2 years now, a year and a half now. And she refused to move.
Okay. This is very different even from a recent tour that I did of the Psychiatric Institute of Washington, right? In terms of the security protocol in a tour going in, right? Number one, security is very visible and present, but also how you all are describing the units of one way in, one way out is not normal.
Yeah, it's not.
Yes,
I think the biggest frustration here is that the population has changed.
yes.
But when we have an administration that continues to stay in the old St. Elizabeth, the population has changed to more forensic. We have more dangerous patients coming in. We have patients who are malingering. We have patients like this particular individual in care. I used to work on that unit. That individual in care is not on any medication, nothing. And we expected to take care of this individual who is responding to command hallucinations, meaning that if the voices tell him, go out and kill that person, he's going to come out. He's going to come out. He's not on any medication to control that. We are expected to take care of that individual in care. And if we don't, we are being blamed. We're being labeled. I got transferred with another colleague from that unit. There are other staff members who got injured. There are other things just happening. No restraint. Nobody is looking into management. Management is not looking at it and try to look for a way to manage these situations.
Ms. Boyd, how many of your bargaining unit are out on some sort of medical leave as a result of issues that occurred at work?
Most of them, there's only one that I know of that's not my bargaining member. It's ASME Metropolitan. A lot of our behavioral health techs, local 2095, she's coming up to speak. She can speak on that. But a lot of our members are being injured and they'll just come back to work or they'll have to utilize their own leave or they won't be, we don't really get the stats because they're afraid to report it. They don't, when you try to press charges or say that there's an issue, they don't want the police come and say, well, I mean, this is the environment that you work in. We really can't do much. They're already here for other charges. So it's kind of like nothing happens about it. And so unfortunately, it's kind of like in other facilities where it's totally forensic, how come those individuals, if I'm assaulted, how come they can't go back to DLC where they're originally coming from? Because they're not here for care. They're here to assault. They're not here for the treatment that we're trying to provide.
Yeah. Okay, we have some data in terms of staff injuries that we'll take a look at. Thank you all for being here and for your testimony. If you just turn off your mics on your way, because we're getting some of the feedback, but thank you guys. And if you can upload your testimony for the record, that would be helpful. Okay. Chris Gamble, from Children's Law Center. Amber Belfus. Is Amber here? All right, Lee Beers, Children's National. Serena Childress. Richard Bebout. Yes, okay. Okay, Chris, when you're ready.
Good morning. My name is Chris Gamble, and I'm a behavioral health policy analyst at Children's Law Center. Thank you for the opportunity to testify today. This is a tight budget season, especially for the health sector, but we must acknowledge that behavioral health services for children in DC were struggling before the current moment. Staff turnover, gaps in the continuum of care, and inattention to quality of services are pre-existing conditions of our system that are not addressed by this budget. We know money is tight for the government, but the same goes for families in DC facing a looming recession and experiencing enduring poverty. Financial hardship and economic downturns are associated with higher rates of suicide and can affect children's mental health through the stress put on their parents. We can't put families at further risk by decreasing access to behavioral health services in a time of need. Alarmingly, the Children's Crisis Team CHAMPS is being almost completely defunded. If the community response team ends up responding to more child crises because of this, it should be noted that in FY24, the CRT responses to child crises resulted in twice the rate of involuntary hospitalizations as CHAMPS. Cutting CHAMPS is also harmful because crisis teams build capacity to respond to crises even for licensed clinicians. Schools need access to child crisis teams when a student's crisis escalates beyond the assessment and management that a school-based clinician can perform, and not all schools even have a clinician. CHAMP staff are trained to make tough decisions around hospitalization and coordinate transportation when needed. Without CHAMPs, schools will only have the police to call when a student is in crisis, the exact scenario we have been trying to move away from. There's never a good time to cut crisis services, but the decisions made in this budget are even more difficult to make sense of, considering the lawsuit the district currently faces regarding inadequate provision of crisis services and over-reliance on police. We asked the committee to restore funding to CHAMP so that the system is not further hampered. One way we can strengthen future development of our crisis system is through a 988 telecommunications fee. 11 states, including Maryland and Virginia, already utilize this monthly fee. There are many ways to structure it and use the collected funds, such as for call center functions, mobile crisis teams, and crisis stabilization services. If we established a 988 fee at the same rate as our existing 911 fee, which is 76 cents, we could generate $13 million annually, which easily covers CHAMP's FY25 funding and even its FY23 funding level when it last operated 24/7. We can respect children's unique needs and get closer to meeting them by using the right tools. We ask that the council explore the benefits of a 988 fee as one of these tools to put us back on track. The changes made in this budget will make it difficult for children to access the care they need, leading to long-term intergenerational harm. My written testimony has more details on the topics I've spoken about, and I welcome any questions you may have.
Thank you. Dr. Beers?
Thank you. Good morning, Chairperson Henderson. My name is Dr. Lee Beers, and I'm a professor of pediatrics and the director of the Community Mental Health Core at Children's National Hospital. Thank you very much for the opportunity to provide testimony today, and most importantly, for the committee's continued focus on the behavioral health needs of children and families in the district. Children's National remains deeply committed to the health and well-being of children and adolescents across the district. We want to begin by thanking Dr. Bazran and the department for their leadership in updating their behavioral health children's plan. I'm delighted to be part of that newly formed work group and look forward to collaborating together on this initiative to improve the pediatric mental health system of care. We also want to thank them for their continued support in addressing the youth opioid crisis. The funding allocated to expand prevention, treatment, and recovery services for young people is a critical step forward. These investments are already making a difference by improving access to care and supporting youth and families grappling with the negative impacts of substance use through our addictions clinic. However, in addition, we strongly support adequate funding for a robust and full continuum of care to ensure our children and youth have access to the care they need when and where they need it. With that in mind, we're seeking further understanding regarding two significant proposed reductions in the FY 2026 budget. As you heard, a $1.2 million decrease in youth crisis services and a $2.3 million decrease in school-based behavioral health services. Children's National has seen firsthand the benefits of trauma-informed, community-based approaches to managing youth behavioral health crises. Through our collaboration with the Child and Adolescent Mobile Psychiatric Service, CHAMPS, we've witnessed the profound impact of these services. In the past 8 months, we've not had to wait longer than 30 minutes for them to arrive. Their quick response ensures that children in crisis receive the necessary assessments and interventions in a manner that's supportive and fosters a sense of safety in a time of intense distress. The services provided by CHAMPS provide critical real-time support to help stabilize young people and avoid unnecessary hospitalization. Similarly, school-based behavioral health services are a vital part of the continuum of care. They ensure that students have access to care in a trusted setting, which promotes early intervention and helps reduce barriers to care. We know from experience that when school-based resource services are well-resourced, they play a transformative role in supporting student well-being. Given the central role these programs play in the district's behavioral health ecosystem, we strongly support the presence of appropriately trained youth-focused teams for youth crisis support services, as well as ensuring that schools have adequate behavioral health staff in place. While we also recognize the fiscal challenges the district faces, and we appreciate the thoughtful work that goes into balancing competing needs, we want to ensure that these vital services remain strong and available to youth and families who rely on them. Children's National remains a committed partner in building a coordinated, responsive behavioral health system for district youth. We'll continue to work with DBH and with the committee and other stakeholders to ensure that every child has access to timely, high quality, and appropriate behavioral health care. Thank you so much for the opportunity to testify and happy to answer any questions.
Thank you, Dr. Beers. Ms. Childress. Hold on, Dr. Beers, can you turn your, there we go.
Good morning, Ms. Henderson. I would like to first thank you for allowing us to speak on our behalf. As you can see, I'm with the union. I'm with the DCNA union, but my union is 1199 DC, Chapter 2095, and I'm the president on both parts. And I would like to speak on their behalf. A lot of them couldn't come because, as usual, they're at work. So I want to piggyback on what everybody said, and everybody said something really well because we all feel the same thing because we work in collaboration. But most of all, I would like someone to address management. We're not getting the support that we need from management when it comes to the assaults that we have been endured in there. And it's been going on since 2015. I was here before in 2019 when a nurse was assaulted in this building. And to this point, we're still going through the same thing, if not more. We have staff that we had 446 assaults in that building from March of 2024 to March of 2025, 132 assaults on staff from March 2024 to March 2025. At this time, our behavioral health technicians, there's a prism that's available, but that I have right now BHTs, which is behavioral health technicians, that I have about 6 that's out. One that was injured with his leg and he has to get surgery. Another young lady, her shoulder was dislocated. She has to get surgery. And this is behind a gentleman that sits on another unit. It's through the whole building, but we're dealing with the most difficult patients that ever came in this facility ever, because they're more younger, they're more stronger, they more from drug abuse behavior. They'd have no care for life because they know they're getting ready to do some hard time for their charges. We have murderers, everything. And you name it, we got it. And so we're standing in the middle of the hallway, I'm like on the floor with these people with no protection. We're just straight up with them, nowhere to go because we have to be on the floor to help them. But some of them are not there for help. They're just coming from DC, from the jail, to spend their time there, to do some of their time there so they can enjoy whatever we have at St. Elizabeth Hospital. Because there's no locked doors or nothing. It's just one way in and one way out. And like the nurses said, we are trapped. There have been people trapped. Recently, there was a gentleman, he was on the floor and he was stomped. The patient beat him, bust his head to the floor and stomped him. This has been brought to administration since 2010. And we still saying, they're still telling us, oh, we're going to do something. We're going to do something. Nothing. They have no idea what to do or how to help the staff with the issues that's going on in it. And the first thing they say is we have no control of who comes in and who goes out. So we're asking that we get some type of safety pay as well as funding for safety pay and funding for more safety care training, safety things put in place so we can be safe when we come to work. We have family too. And I was injured. I'm sorry, I'm going on my time. I know that. I was injured twice, sexually assaulted in 2019. And then I was physically abused in the midst of sexual assault and assaulted again. And I've been there 18 years. And I'm to the point, enough is enough. I have family I want to go to. I don't want them with my eye hanging out and they got to take care of me. Also, I would love for them to put more funding into the life insurance that we endure at that hospital. It's not enough. And I thank you for allowing me to speak.
Thank you. I'll have some follow-up questions. Dr. Bebout.
Good morning, Chairperson Henderson and members of the committee. My name is Dr. Richard Bebout, and I'm Senior Director of Behavioral Health at Unity Healthcare. Thank you for holding today's hearing on Mayor Muriel Bowser's proposed 26 budget for the Department of Behavioral Health. I'm very pleased to be testifying on behalf of Unity and would like to begin my testimony by simply acknowledging how extraordinarily difficult and challenging this budget season has been. By way of background, Unity is the largest community health provider of primary and specialty care in the District of Columbia, serving more than 76,000 patients annually through nearly 400,000 patient visits. Our patient population is notably diverse, with 90% of our patients identifying as people of color and more than 90% being uninsured or publicly insured. Unity operates more than 20 delivery sites across the district, in the community, at low barrier homeless shelters, in schools, and within the DC jail. The mayor's proposed budget is the culmination of an impossible balancing act under the worst possible circumstances, with incredibly difficult choices surrounding Medicaid eligibility and the Alliance. In the face of these challenges, Unity is committed to doing whatever is needed to build on successful ongoing collaboration with the district government. My testimony will highlight a couple examples of this. I first want to point to the impact of substance use disorder treatment at the DC jail. Research on the cost effectiveness of substance abuse treatment is clear. Every dollar spent on SUD treatment reduces healthcare costs by $4 and criminal justice costs by $7. Thus, especially in these difficult financial times, it must be remembered that investments in SUD treatment pay for themselves. Over the past several years, and with the support of the Department of Behavioral Health and Department of Corrections, we have expanded Unity's SUD services at the jail. With funding from SAMHSA provided by DBH, the DOC and Unity have quadrupled the number of residents treated for SUD in the past 4 years, from 90 patients monthly to over 400 patients per month, reaching more than 1,200 individuals last year. Furthermore, we work constantly to strengthen discharge planning efforts to assure access to care through one of Unity's community health centers or elsewhere immediately upon release from the jail. My written testimony highlights our work in pediatric and maternal behavioral health. I'm going to skip ahead because of time and urge the committee to vigorously support efforts to launch the Certified Community Behavioral Health Clinic model in the district, because it couples more sustainable funding with greater accountability and attention to outcomes, along with requiring same-day access and robust crisis services integrated within the clinical home. We believe the CCBHC model represents the best vehicle available to drive reform. There's additional detail in my written testimony, but on behalf of Unity, we stand ready to continue to support the Department of Behavioral Health to ensure delivery of high-quality health care, including behavioral health care.
Thank you. Thank you so much to this panel of witnesses for your testimony. Mr. Bebout, I'll start with you. Dr. Bebout, apologies. I'll start with you. From the perspective of the work that you all do at the DC jail, which the health unit at the DC jail is designed as a forensic unit, but it for a variety of different things, right? Somebody got a cut, someone is sick, someone in need of SUD treatment, et cetera. I know that I didn't give you advance warning on this, but what is your immediate thoughts in sort of hearing some of the testimony from the individuals who work at St. Elizabeth's Hospital around the need for increasing sort of security protocols to match the population, even in a healthcare setting? You turn your mic on.
Thank you for the question. Let me try to answer it a couple of ways. One is to just underscore that Unity is involved throughout the jail, and in addition to having the infirmary, urgent care, and a number of specialized units for the treatment of people with serious, there's an acute men's unit, a step-down unit, acute women's unit, and specialized units for substance abuse treatment. Clearly, in my opinion, there needs to be more education of the judiciary about the level of acuity and treatment resources that are available through Unity at the jail. There are a lot of dynamics that do not have to do with healthcare that drive when people are ordered from the jail to the hospital and when they're permitted to return to the jail. So it's a very complicated, I was with Unity at the jail previously. I've been at the Department of Behavioral Health. I am pleased to say that there is very strong coordination and care coordination when people are moving between the jail and the hospital and back, between the treatment teams there to assure continuity of care. I'm not sure what else to say.
Yeah, I mean, I just sort of, right. I rarely hear from Unity doctors and staff about a variety of different things. I rarely have 20 or so of them at a hearing talking about not feeling safe in the jail. But now I have 20 or so nurses here saying they don't feel safe at the hospital. So something's different, even though it's the same population, similar population of individuals in terms of their crime.
Yes, structurally, they're wildly different. The correctional environment from the hospital environment, for sure.
Okay. Ms. Childress, thank you for being here and for representing the members of your unit. Now, what was interesting is that we had pulled up the report that we received from Department of Behavioral Health around the number of assaults that have taken place. And then you gave your readout. We've got two different numbers, wildly different, in fact. So for the year, they are reporting 75. I think you said assault on staff is at 132. Go ahead.
So the prism that they submitted to, because the union gets the prisms that they have. And I looked at it last night and I was looking at it and I was like, okay, physical assaults at the top, it said total and it said 446. So I don't know if you have the same one. And then physical assault, and then it said staff assaults was, I think the physical staff assaults were 123. Unless I have an old prism, I don't think I do.
Yeah, no, we have the prism too. That's
Okay.
what we're looking at.
Well,
It's okay. I mean, I'm always of the, like, we
I
can't
can
really
be
have a
corrected. That's
right.
fair
No,
enough.
but in just sort of an understanding, right? I need to know, like, are they underreporting or are there
yes,
other things?
I'm gonna be honest. Yes, they are.
Okay.
Yes, they're underreporting. And most of the time, that's what the prisms do because we have MUIs and then we have UIs. So MUIs is assaults and everything that goes on throughout the hospital.
What does that stand for?
Okay, so MUIs is a major incident report, like for assaults and aggression and things like that.
Okay.
And most of the time, the staff will document it and give it, and it goes through a computer, right? So that means everybody who's supposed to get it gets it. For some reason, when they do their prism, it never comes out right. And we addressed that on 7 occasions with Mr. Chastings to please get everything right. And then we was informed that, oh, yeah, we separate, we don't put all the MUIs. Well, if it's assault, it's assault. Whether it's physical, mental, whatever, assault is assault. If I grab this lady and pinch her, that's an assault. So they try to like separate how serious an assault is. And then they say, oh, we're doing good because we only have. But meanwhile, we're every day every day, Chairman.
Yeah. Okay. Thank you. Thank you for being here. Dr. Beers, Mr. Gamble, thank you so much for being here and advocating on behalf of CHAMPS. Well, not just CHAMPS, crisis response specifically for youth in general, which I think sometimes, first we said, oh, we don't need it 24 hours. Now we're saying we don't need it at all, which is a question mark in my mind because while our crisis response team at DBH is, good, they are also strapped in terms of staffing to be able to appropriately respond to the number of calls that they are receiving. We did a hearing on a resolution that the council introduced around crisis response and the need for the executive to have a better plan in terms of staffing to address these issues. But Mr. Gamble, I'm going to give you a gold star today because you're the only one so far who has come and said, this is how y'all can raise some money. Right? I have a problem. I know how to pay for it. This is the type of things that we need in this environment. How many other jurisdictions have a 988 fee?
So right now it's 11 states, I believe 8 more have a pending legislation. And there's a lot of different ways that they structure them. Some started off in the first year a little lower and it gradually goes up. Some have it where because it's a per phone line per month. Some have it, if you have like a prepaid cell phone, it's a lower rate. So it doesn't have to be a flat fee like our 911 fee is. So yeah, there's a lot of flexibility there, flexibility in how it's used that I have more detail about in my written testimony. But yeah, if it were structured the same way as our 911, 13 million is what it would generate, which, as I said, could cover CHAMPS. It could cover, I believe, the Access Helpline. Maybe not fully the CRT, but it's an extra 13 million to use.
Yeah. Well, and I also feel like the connection of the two, one of the things that I talked to my colleagues about when they are saying like in terms of revenue, and not just that, but also the executive. We have these specific fees or assessments for a specific purpose. And it is very frustrating when the executive then swipes that and uses it for trash pickup or something completely different.
Yes.
Because me as a person who believes in public health and the full continuum of care and things like that, where I'm like, okay, great. I think when I see my cell phone bill, the 911 fee is going to support 911.
Mm-hmm.
The same with 988. All right, that's going to support individuals who are there, who can answer the call when someone is in need of crisis and in help. And therefore, I get very little complaints about a 911 fee. I get lots of complaints about these other things. And so to the extent that we can, tying it to one or the other. But let me ask you this, because where some of my skepticism sort of would drive on something like this is if we just if we put money into a system that is not working, is there something that we should be changing about crisis response for young people to improve it before we fund just the old contract that there were criticisms? Dr. Beers, I appreciate that you said, you had maybe a 30-minute wait, but that is not the norm or standard that we hear, even if a school calls or something like that. It's usually an hour or two that they're waiting. So how do we improve that?
So I'll say, and I believe someone from CHAMPS is testifying later today, so I could let them speak about their functioning overall. But as myself being a licensed counselor who has called CHAMPS before, yes, I've seen the range of responses. But I think it's also important to look at our crisis response system, specifically if we're looking at 988 as developing into the front door of the crisis system. We're in a very early stage. 911 started in like 1968. It took 20 years for even half the country to get access to 911. So as far as crisis response, creating a cohesive system, we're in the equivalent of like the early 70s of 911. So I think even if we see some shortcomings, we have to keep that future looking view of like, we're building towards something. Just because it's not working amazing right now doesn't mean we should stop, because, and not to say that 911 is perfect either, but if we want to develop into a cohesive system where every jurisdiction has something where people can expect a certain type of response, we have to invest in it.
Thank you. I'll let you, oh, Dr. Beers.
I think the only thing I would add about that is I do think one of the things that makes the partnership with Children's National and CHAMPS so strong is that there is actually a partnership and a relationship. And so I think investing in ways to help build that to help build those relationships with the other places like the school so we can better understand what the needs are, what the staffing needs are, what the response needs are, I think will help it because I do think that partnership is one of the things that helps with the response, right? And it makes it so strong.
Yeah. All right. Thank you all so much. If you can make sure you have your testimony for the record. And thank you. Okay, we're going to our next panel. It's going to be a truly hybrid because we're going to bring in the virtual folks. So if you're online, now's your time to shine. Just to let the folks online know, just as a reminder, you have to affirmatively accept our invitation for you to become a panelist. There'll be a little box that pops up when it's your turn. It'll be a little box that pops up when it's your turn, and you need to accept that there. All right, so we're gonna do. All right, we're gonna try 7 and then see where we go. And one of those will be Miss Deborah Thomas from the Nurses Association. She's in the room. Then we'll go Jaron Hill Lockridge, the chair of the Ward 8 Health Council and Dreaming Out Loud. Shannon Walsh, clinical director, Pathways to Housing. Will Doyle, Pathways to Housing. Christy Respris, Pathways to Housing. Carrie Savage, chief of policy at PAVE, and Kiana Lemons, who's a parent leader at PAVE. Okay, I have one who is off. So Sean Boone Ruffin from PAVE will add you as well. All right. Ms. Thomas, when you're ready.
Good morning, Madam Chair. I am sorry that when you called my name earlier, I wasn't here. I had given the Lyft driver the wrong number, the wrong address, so I was somewhere else.
Okay, it's okay. You're here now.
A lot has been said already from St. Elizabeth's. First of all, my name is Deborah Thomas. I'm a nurse consultant for the DC Nurses Association. And one of the units that we cover is the Department of Behavioral Health. I have been coming down here to testify for behavioral health since 2019, and we had a very serious incident where a nurse was injured and her face was all over the city. And we had nurses in this chamber standing saying, never again. Well, that never again has turned into routine violence now in the setting that has just been normalized. I meet with St. Elizabeth's administrators at least once a quarter to report on what is called assignment despite objection. These are some of the reports that nurses send in to our organization about what's going on. We collate that data, and we have what is called assignment despite objection. Well, the first quarter of this year is showing the same levels of violence without any changes. This has progressed to nurses just being forced to work in inhumane conditions of work. Now, what we want, and the nurses have said, is shields on all nurse units, more security guards on the units, but more collaboration with the psychiatric staff. As long as I've been going to these meetings with administration, psychiatry is never included. Some of the problems that we're having our patients is attributed to that, because some of what the doctors or the psychiatrists are recommending is not really good for the staff. Development of collaborative strategies with nurses, psychiatric, administrative staff to promote safety. Most importantly, what hasn't been said, St. Elizabeth's cut their education department. They are not delivering education to these nurses to give them updates on what is going on. And you got a new population coming in, has increased, and nothing has changed. That is the one other thing that I wanted to mention. There's another thing I wanted to mention is the provision of adequate supplies and equipment. We have a glucose monitoring system that is outdated, and the competency of those results must be considered. There's no backup comparison for it. The thing that is, there is new technology out there that can make care easier and with the population and the patients. And the provision of supplies for activities of daily living. Early in 2024, the nurses were actually bringing in soap, shampoo for the patients because they couldn't get it. So that's part of agitating a group of patients that are already agitated and they didn't have the decent supplies. So what we're asking the council to do is to make sure there's money in the budget to make sure we have a safe workplace. But we also have supplies. In the middle of the year, sometimes they stop and say, oh, we can't order supplies because we don't have any money. So we need to make sure that we have the money to promote a safe environment and a therapeutic environment for our patients and decrease the levels of violence, but also to make sure there are decent supplies so that nurses can deliver their care as well.
Thank you.
Thank you.
All right. Jaren. She's not with us. Okay. Shannon Walsh.
Good morning.
Morning.
Morning, Chairperson Henderson, council members, and council staff. My name is Shannon Walsh. I'm a Ward 8 resident, a licensed independent clinical social worker, and the clinical director of the Court Urgent Care Clinic. The Court Urgent Care Clinic is a partnership between DC Superior Court and the DC Department of Behavioral Health and Pathways to Housing DC. Each year, the Court Urgent Care Clinic provides hundreds of adults with mental health and substance use challenges with same-day assessment and treatment of complex behavioral health challenges. The clinic was one of the first and remains one of the only of its kind in the country. On staff, we have a psychiatrist, 2 mental health clinicians, a certified addictions counselor, and an intake coordinator. Our office is in a unique position to provide services to individuals regardless of if they have an ID, insurance, or residency status in the United States at no cost. We're conveniently located inside the DC Superior Courthouse to provide services to individuals involved in the court who often fall into one or more of these categories. Although we are located in the courthouse, we are able to provide services to anyone in the district regardless of court involvement. According to our human care agreement on page 8, the Court Urgent Care Clinic's objective is to support DC residents who are court involved, minimize recidivism within the criminal justice system, augment justice diversion programs, and triage the behavioral health needs of the consumers served there so that they will be connected to appropriate long-term care. In the first 10 months of our contract year, 88% of our clients have reported their interactions with the Court Urgent Care Clinic positively impacts their judicial disposition. 66% of our clients were discharged with a positive outcome, such as being connected to a long-term mental health or substance use provider. And 46% of our clients were referred for a housing assessment due to experiencing homelessness or housing instability. Contract year, the clinic is on pace for 845 unique referrals, 1,029 assessments, 6,108 follow-up visits for the year ending September 30th, 2025. Despite continued threats to funding, demand is increasing by 21%, and we will exceed our contract by 41% this year. The Court Urgent Care Clinic also provides forensic child evaluations at the request of the court to determine if a child needs to be hospitalized. We've been able to avoid hospitalizing a child after gathering the needed information and coordinating with the hospital, the child's probation officer, family, and core service agency to be prescribed the appropriate medication to avoid hospitalization. Unfortunately, our program has been proposed to be cut in fiscal year 26. This would be a tremendous loss to our clients and community. The benefit of having our office in the courthouse is that clients can be seen on the same day they are in court and experiencing acute mental health symptoms. If our program is closed, our clients will likely have to travel to another location, which is an added barrier and will likely result in the person not getting the treatment that they need. The Court Urgent Care Clinic stands in the gaps for clients who may already be connected to mental health providers but need immediate psychiatric intervention, including emergency medication, counseling, and involuntary hospitalizations. Recently, we had a client come to us who had been released from St. Elizabeth's. Because they were experiencing homelessness and had no contact information, they were not aware that they had been connected to an assertive community treatment team. With our assistance, they were able to be linked with their provider and get the holistic care that they needed. Another recent client came to us because after many years of substance use, they were ready for treatment. We were able to assess the client and get them into inpatient substance use treatment on the same day. The services UCC provides are life-altering, not only for our clients, but our community.
Shannon, I'm
Our
so
state-
sorry.
yes,
You are well
that's
over your
okay.
time.
That's
I'll
okay.
have some follow-up questions.
Perfect.
I've been strict through now, so I can't.
No,
let it-
that's good. That's
Okay.
good.
All right, Will?
Thank you, Chair Henderson and Council staff. My name is Will Doyle, and I'm the Vice President of Housing First at Pathways to Housing DC. I'll focus my comments on the Court Urgent Care Clinic, which DBH has proposed to completely eliminate in its FY26 budget, despite the significant demand for its services and the key role it plays at the DC Superior Court. The Court Urgent Care Clinic is unique, as staff provides same-day mental health and substance use assessments and treatment at the DC Superior Court. For those experiencing a mental health crisis, whether a child or an adult, clinic staff provide immediate access to assessments for involuntary hospitalization, avoiding escalation and incidents at the DC Superior Court. Clinic staff also provide immediate assessments, transportation, and access inpatient substance use treatment, avoiding gaps that often prevent successful entry into treatment. The Court Urgent Care Clinic is required to minimally serve 600 unique referrals annually. In FY24, the clinic had 697 unique referrals, 821 assessments, and 4,157 follow-up visits. In FY25, the clinic is on pace for 845 unique referrals, 1,029 assessments, and 6,108 follow-up visits. Despite continued threats to funding, demand is increasing by 21%, and they will exceed their contract by 41% this year. When unaddressed chronic behavioral health needs are displayed in the DC Superior Court, the Court Urgent Care Clinic supports individuals in connecting to ongoing community-based services. However, there are multiple steps to that process, so clinic staff provide ongoing intensive case management and clinical services for up to 90 days to ensure continuity of care while clients are getting fully connected to community-based services. This is a key role, as without ongoing support, most will not successfully connect for services, contributing to continued engagement with the criminal justice system at great expense to DC government. In FY24, the clinic consistently served 80 to 95 clients through ongoing services. In FY25, the clinic has consistently served 115 to 145 clients through ongoing services. That represents a 49% increase from FY24. If the clinic is eliminated as planned, the need for its services will not go away. They will simply be unaddressed. The clinic serves individuals who are not adequately accessing behavioral health services elsewhere, and are doing so due to the unique location and services of the Court Urgent Care Clinic. Without the Court Urgent Care Clinic, we will see increased use of 911, fire and emergency medical services, the Metropolitan Police Department, the DBH Community Response Team, CPEP, and the Department of Corrections. Do they have money to spare in their FY26 budgets to cover increased demand? In the current context of potential cuts to Medicaid and SNAP, as well as local services and benefits that act as a safety net, funding the Court Urgent Care Clinic is even more important to support the additional DC residents who will be pushed into crisis. Funding the clinic also serves as a statement of DC values in the face of federal pressure to reshape DC in its own vision. I urge you to focus on the many DC residents whose needs will not be met if the Court Urgent Care Clinic is eliminated, and restore funding for this crucial community resource. I'm happy to answer any questions.
Thank you. Carrie?
Good morning, Chairperson Henderson, members of the Committee on Health and committee staff. My name is Carrie Savage, and I'm the Chief of Policy at PAVE, or Parents Amplifying Voices in Education. PAVE is also a member of the Strengthening Families Through Behavioral Health Coalition, a coalition committed to ensuring that DC children, youth, and families have access to a fully integrated behavioral health care system that meets the need of the whole child. Thank you so much for the opportunity to testify today on the funding for behavioral health, the Department of Behavioral Health, an agency that helps provide essential services to support the health and well-being of district residents. As you will hear from many PAVE parent leaders today, some of whom are toggling between the education agencies and DBH, DBH and their work to support school-based services are a core part of taking care of our kids. It matters during school hours to ensure kids can show up as their whole selves to learn, but the impacts extend far beyond the bell. It shows up when kids engage with others after school and summer programs and build community, take risks as they explore new passions. It matters when they are traveling to and from school and avoid unsafe or negative behaviors. It matters when they are preparing for big choices around college and career and making plans for themselves about how they will thrive independently in an ever-changing world. And it matters when they are navigating the increasing complexities and challenges of growing up today, from trauma at home or in their community to harmful impacts of social media to finding their own authentic identity when not all environments accept who they really are and want to become. When done well, school-based mental health services are provided not only after an issue or challenge escalates, but also early and thoughtfully. Tier 3 services should be a component of prevention if we are in tune with our students and have the right interventions and care available. For all of those reasons, we have to fund this work to keep it feasible. It is no secret we are in challenging times. The DC's financial picture is tight, and as we weather the impacts of the changes from the federal government, we have hard choices to make as we try to balance the many needs of our communities. Our ask today is to find the money to prevent cuts to current services and sustain a reasonable minimum grant amount for our current providers to avoid loss to clinicians and therefore care. From the budget books, it is unclear how deep that cut is to the school-based mental health expansion, and we hope that Council prioritizes this funding. Additionally, it is paramount to improve information sharing and clarity around what coverage will extend to families with insurance. It will make the funding for DBH and any other entities that provide Tier 1, 2, and 3 supports for students go so much further if families understand what supports are available and how to navigate accessing them. I encourage DBH to continue to visit and partner with schools that are doing this well and work collaboratively to develop and refine resources and practices that help expand what works. DC has made laudable progress in the school-based mental health space overall. DBH can and should be nimble and responsive to the needs of school communities, as evidenced by their work to allow schools to use grant funds to hire clinicians directly. We need creative and innovative problem solving to continue that trajectory and make sure we protect existing services and do all we can to get more support to more kids in schools. This work is only possible with leaders on the Council and DBH who believe in the power and promise of community voice. Thank you so much for the opportunity to testify today. I hope that we can count on your leadership. Thank you.
Thank you. Kiana.
Good morning, Councilman Member Henderson and members of the Committee on Health. My name is Kiana Lemons. I'm a proud Ward 7 resident and paid parent leader. All of my children attend DC public schools. I'm here today to speak about the critical importance of funding school-based mental health support. In the proposed budget for fiscal year 2026, the budget for the school-based mental health services is facing at least 2.3 million cut, but it could be more. I'm here today to urge the Council to restore the funding so that our students can access mental health support they desperately need. School-based mental health allows students to receive the support they need to build coping skills and learn how to handle difficult situations and express themselves. When students have strong mental health support, they are able to navigate through their trauma and focus on their education. The more that they are able to focus, the more that they are able to learn. This can lead to improved more math and literacy skills for the district students. We want our children to do their best that they can, so let's make sure we set them up for success. When children don't have access to proper mental health support, they may use negative coping skills. These negative coping skills could lead to and could involve harming themselves or others. We want schools to be a positive place where kids can learn. We do not want kids to miss out on access to services that they need to build a positive environment. We want our children to go to school, to increase their attendance, and continue to grow in their math and reading skills. We want the safest environment for our children. Equipping schools with the proper trained therapists help us do just that. When thinking about my son's academic journey, I know that access to properly trained mental health professionals will have a positive impact. Right now, he is having a tough time navigating his emotions at school. A mental health professional could help equip my son with the coping skills he needs to thrive in his school community. As he gets prepared to go to middle school, I urge the council to restore funding to school-based mental health services or merely sustain the reasonable minimal grant amount for our current providers to avoid loss of connections. So my son and students just like him can get access to the support that they need to be the best version of themselves. Thank you for an opportunity to testify. I'm here to answer any questions.
Thank you. And Ms. Boone Ruffin.
Good morning, Councilmember Henderson and members of the Committee on Health. I am Sean Brun, a Ward A resident and a paid Ward A and citywide PLE board member. I'm also a Dunbar High School Engineering Academy and Hope Toasting Public Charter Academy parent. Soon to be Learn Charter School, yes, a new school. Thank you for the opportunity to testify. I'm excited to share my perspective as both a parent and educator and a professional mental health on the importance of school-based mental health services. Access to mental health services is what keeps us going. It helps students show up to school with the skills they need to be present and make connections with friends, build relationships with teachers, and dig deep into their learning. Our children are living through uncertain times, and equipping them with the tools they need to thrive is essential. I'm a resident marriage and family therapist. During the COVID-19 pandemic, I worked closely with teens and their families to help them navigate their mental health during a time of crisis. I saw firsthand the positive changes in teens as they were able to access the support they needed. When kids are able to express themselves, understand their emotions, they're both able to handle tough situations. In my eldest daughter's educational journey, access to mental health support has been life-changing. In middle school, my daughter was struggling with her anxiety. I connected with her teachers and principal who helped her receive services from the in-school therapist. This therapist gave my daughter the tools she needed to manage her anxiety and thrive in classroom. In fact, she did so well that she is now a part of a pilot program at Dunbar High School for AP honors students and is on track to graduating early next year, sorry. However, when she left middle school, she lost access to her mental health support in school. When trying to access in-school mental health support in high school, my daughter was unable to be connected with the in-school clinicians since we have private insurance. We have tried to access in-school support 3 different times with 3 different mental health professionals and 2 different companies. So far, we have been unable to receive services. We must continue to fund school-based mental health services so the programming can expand to support all students, no matter whether or not they have private insurance. Funding school-based mental health services is essential. All students deserve to thrive. I have seen firsthand the positive impact access to mental health support has had on my daughter's life. We must restore the $2.3 million that has been cut from in-school mental health services or minimally sustain a reasonable minimal grant amount for our current providers to avoid loss of clinicians. We want the district students to excel. Let's help them to do that. Thank you for the opportunity to testify today, and I look forward to answer any questions you may have.
Thank you. Thank you so much to this panel of witnesses. I'll start with Ms. Thomas. Thank you so much for, I think, summarizing very well some of the testimony that we heard from the earlier witnesses as well. And I wasn't a council member in 2019, but I do recall, you read the news, you couldn't miss what happened. And it is disappointing that we're here again, but I think part of that is a failure to recognize how the population has changed dramatically and not making the staffing or facility changes to address that. I think is something that we're hearing, but also, this idea that there is now no long-term care option for someone who is not going through the court system, but is in need of services, that is something we also have to talk about. We had a hearing, what is time? At some point in the last year. Actually, I think it was in December. We had a hearing with the Deputy Mayor for Health and Human Services, the Director of DC Health, the Director of the Department of Behavioral Health. And the question I asked them was, If the Psychiatric Institute of Washington closed tomorrow, what's your plan B? Because that is a private entity. And what are the other options that are available for care should that private entity decide they no longer want to do business in the District of Columbia? And what does that look like for the continuum of care? We still don't have a plan. And we need to work on that. But thank you for being here. Ms. Walsh and Mr. Doyle, thank you for being here. I think that the work that is happening at the Court Urgent Care Clinic is crucial and helping to support the overall functions that's happening at DC Superior Court. And I know that there is this mixture in terms of responsibility because DC Superior Court is quote unquote part of the federal government. But there's still very much acting as though our local, judicial system. Let me ask you this. Have you all had conversations with the court administrative offices about what it might look like for your services to continue, but not as a part or as a grantee of DC government? As a grantee of them?
We haven't spoken directly with anyone from kind of judiciary, but it's our understanding that we've heard from judges and other stakeholders is that there's not money for it. So I think everybody would like to fund it, but they don't have it in their budget to like replace the funding from the Department of Behavioral Health.
Okay. And if we were to fund it in FY26, what's the overall total cost?
I believe it's $907,000.
907. I love it when it doesn't end in a 1 or a 0. That means you guys have done the real work. Okay. In besides the Department of Behavioral Health, what other agency within district government do you all have a relationship with that exists that is related to this work? Is there anyone else that you all work with on court urgent care type matters? Obviously, Pathways to Housing, you have a relationship with Department of Human Services, but is there anyone else that you all are talking to within the judiciary and public safety cluster?
Not at this time. We mostly are just communicating with the Department of Behavioral Health. Pathways, of course, does have good relationships with like you said, the Department of Human Services. So there's been some discussion there, but none that's really gone very far.
Okay. I would make a suggestion to you is that you all invite the Deputy Mayor for Public Safety and Justice to come essentially do what I did, which is to sit in the courtroom, see the interaction in a couple of cases, and then also sort of the referral piece of what is happening out of your small but mighty office in terms of how you are providing support across the system. Ms. Savage.
Thank you.
And to the rest of the PAVE leader team, thank you so much for being here and for your advocacy on school-based behavioral health. We have some questions for the department in terms of what their plans are given the reduction in funding or proposed reduction in funding. And then we'll follow up with them. But thank you all for being here, and please make sure to provide your testimony for the record if you haven't done so already. All right, we're going to go to our next panel. Okay, Stephanie Griffith Richardson, Taiisha Andrews, Kristen Jones, Alyssa Gunzi, Elizabeth Freric, Carla Portillio, Gail Avant, Savannah Moss, all right, let's see how many we're getting. Again, you have to affirmatively accept our invitation to become a panelist. We'll add Courtney Harris, Candace Ricks, and Laura Patton, if you are here. Okay, I see Stephanie, when you're ready.
Good morning, Councilman Henderson and members of the Committee on Health. I am Stephanie Griffith Richardson, a Ward 7 resident and Ward 7 PAVE PLE board member. I thank you for the opportunity to speak. I want to begin by acknowledging the incredibly difficult situation we're facing when the federal government treats funding like a game of roulette. Local leaders like you are left with impossible choices. I don't envy that position that you're in. But I urge you, please do not make the deep cuts to behavioral health supports in our school. We've come a long way. I remember the days when one counselor was shared between 2 or even 3 campuses. That wasn't support, it was a triage. As we paid that price, students suffering in silence, teachers overwhelmed, and crisis escalating. Today, students are dealing with mass shootings in the headlines, constant cyberbullying, violence in communities, trauma at home, and a historic rise in diagnosed mental health conditions. These are not hypothetical issues, they are realities, and they require constant and consistent professional behavioral health support and not a Band-Aid solution. We both know past standards weren't support, they were barely survival. They aren't abstract problems, they're lived realities, and they require daily professional support, not temporary patches. This issue is personal for me. My son has ADHD, and so for years he struggled. Not because he wasn't smart, but because he wasn't getting the support he needed. Sorry. Those changes, that changed this year. With access to proper behavioral health services and staff who understood what he needed, for the first time in his life, my son, now in 6th grade, is testing on grade level. I celebrate that moment. That may sound simple, but for us, it's a milestone. It's hope. It's the result of years of advocacy, finally meeting real support. And I don't want this to be the peak of his story. I don't want this to be the year he almost made it. But before the system was pulled out from under him, please protect these services, not just for my son, but for the thousands of other DC students who are finally being seen, supported, and set up to succeed. Thank you for the opportunity to testify today. I look forward to answering any questions you may have.
Thank you. Thank you for your testimony. Taiisha?
Yes, good morning. My name is Taiisha. Good morning, Councilmember Henderson and the members of the Committee on Health. My name is Taiisha Andrews, and I am a proud Ward 8 parent, the mother of 2 incredible children, Terrence Jr., who attends Mary H. Plummer Elementary, and Amari, who is thriving at McKinley Technology High School. I serve as a parent leader with PAVE, as both a citywide and PLE board member. I am also the first vice president of McKinley Tech's PTO and a parent LSAT member at Plummer Elementary. Thank you for the opportunity to testify today. I'm here to advocate for the importance of school-based mental health services. I want to focus on the fundamental truth that mental health is essential to the academic success and well-being of our students. Without meaningful mental health support across every layer of the school community, we cannot expect DC students to reach their full potential. While the district has shown significant growth in academic achievement in the most recent NAEP scores, we still have a way to go. Students' outcomes on standardized tests aren't just academic. I believe they're also tied to a student's emotional health, of course, emotional intelligence as well. Chronic stress, untreated trauma, hunger, housing instability, and community violence all affect a child's ability to learn, focus, and succeed in school. Mental health isn't a secondary concern. It's the very ground we must stand on to build an effective education system. We need fully staffed, trauma-informed mental health teams in every school. Many students act out or withdraw due to trauma they don't know how to process. Teachers are expected to wear multiple hats without emotional support or training, and families are often navigating challenges like food insecurity, eviction, or loss of which ultimately directly impact our students. Providing consistent mental health support can reduce absenteeism and truancy, improve classroom behavior and focus, help identify learning differences earlier, strengthen school and family relationships, and prevent crises before they escalate. This is the path to the real academic recovery and lasting equity in education. We must treat mental health as the core issue. Academic achievement cannot be separated from emotional wellness, and that applies to our students, our families, and our educators. We must restore the 2.3 million in proposed cuts to the school-based mental health services, or minimally sustain a reasonable minimum grant amount for our current providers to avoid loss of clinicians. A mentally healthy student is a successful student. This is how we build the future DC students deserve. Thank you for your time and the opportunity to speak, not just for my family, but all the families across DC that have children that deserve to thrive.
Thank you, Ms. Andrews. Kristen? Kristen, I see your box. So if you're speaking, we cannot hear you. Okay, Ms. Jones, I think I'm going to have to go to the next person. And if you want to close off and then come back on and try again. Alyssa? Gundas?
Good morning.
Oh, okay. Who is, oh no, went away. Who do we have?
It's Kristen. My camera is coming back on.
Okay. Ah, there
Okay.
you are.
Good morning, Council Member Henderson and members of the Committee on Health. My name is Kristen Jones, and I'm a Ward 8 resident. I'm a proud parent of a fourth grader who attends Shirley Chisholm Elementary School in Ward 6. My daughter has attended both DC public and public charter schools. I'm a Ward 8 parent leader with PAVE. Thank you for the opportunity to testify today. I'm excited to share with you my thoughts on the importance of school-based mental health. It is essential to have mental health clinicians in all schools to address the various difficulties our young people go through. My daughter is 10 years old. While she is doing well mentally, I'm worried about what mental difficulties she may face as she gets older. Having access to a school-based mental health professional to guide my daughter through her emotions and to discuss things she may not want to discuss with me will be crucial to her social emotional development and maintaining her positive mental health. Having a school-based mental health counselor in the school would make a serious difference. It would provide a sense of comfort to both students and parents, knowing that there is someone for our young people to learn coping skills and more. Not only is it important that clinicians are based in schools, but it is also important that they are actively involved in the school community, building relationships with students, and visiting various classrooms. Everyone should know that if they're having a problem or facing a difficult situation, that they have a trusted adult whom they can go and talk to if they would like. Students spend majority of their time in school, so we need to meet them where they are. Families may not have access to the resources needed to access mental health support outside of school. Kids have to learn how to express themselves so that they can become productive members of the community when they grow up. It is important to give them social emotional skills they need to be successful as children and into adulthood. It is for these reasons that we cannot cut off at least 2.3 million from the school-based mental health services fiscal year 2026 budget. We must restore the funding or minimally sustain a reasonable a minimal grant amount for the current providers to avoid clinicians ensure that all schools have access to mental health support, and information about how to access this is crucial and it can be shared with students and parents. In closing, I'm a strong believer that we should be proactive and not reactive. We owe it to the students in the district to provide them someone that they can. Thank you for the opportunity to testify today. I look forward to answering any questions that you may have.
Thank you. All right. I don't think Alyssa is here, so we'll go to Elizabeth Freric.
Good morning.
Good morning.
I'm sorry, I'm having to switch my screen here. I'm trying to do this on my phone. My apologies. My name is Elizabeth Freric, a Ward 7 community activist and PAVE parent leader. I come before you today with a heavy heart, but a sound mind. As I look at the world around me, I see people suffering, children hurting, and decision makers simply lost for words and solutions. I choose to believe that I live in a society where people with power use their power to change lives and to restore justice. I believe that the doers will do and the thinkers will think and that the healers will heal. I ask you to take a moment as you make very hard decisions to ask yourself, what is my role here? Who do I show up as in this world, and how does my work lead me in the doing, the thinking, and the healing? I am a mother of 5 children. They all have different skills, learning abilities, and personalities, and it's my job as their parent to identify their strengths, their learning styles, and to create opportunities for them to experience growth. I help them identify tools and resources for them to be successful, not only academically, but in life. I take that job very seriously, but I also understand that not every parent has either the capacity or the knowledge to know how to navigate those waters. For that reason, I became a certified peer specialist to help my neighbors and my community. While I am a doer, a thinker, and a healer, I also know none of these functions can happen without education. Mindsets don't just shift preemptively. It requires love, focus, practice, but most importantly, a desire for change. I have many criticisms of schools regularly, but I want to assure you and the future employers out there, I have been in many classrooms in both DC public schools and DC public charter schools. No amount of classroom management, no amount of teacher wellness, no amount of restorative practice will ever replace the clinical care that is necessary to address the concerns of grief and loss. Our children are grieving daily. I see more street memorials these days than I see kids playing. That is disturbing to me. I'm asking you to ensure that school behavioral health services are fully funded and that mental health services are restored to the best of your ability. I cannot continue to sit back and wonder where my city will be in 10 years because we weren't able to show up for our neighbors when they needed us. It's time that we pay attention to what's in front of us. Trauma can manifest with the same symptoms as mental health disorders. I will say that again. Trauma can manifest as the same symptoms as mental health disorders. We need to shift as a society to acknowledge this and invest in healing practices. A new stadium, a new hospital, a new school will not restore hopelessness. If we continue this way, there will be no workers, no consumers, no patrons to keep these facilities open. Thank you.
Thank you. Carla Portillio.
Yes, hello. Can you all hear me? Okay.
Yes.
Hi everyone. I hope you all are having a good day so far. My name is Carla Portillio, and I'm one of the lead organizers of United Leaders for Freedom, as well as a cohort support through Black Swan Academy. I work in multiple DCPS schools such as McKinley Tech, Hart Middle School, Elliott High Middle School, among others. Within our organization of United Leaders for Freedom, we aim to strengthen youth voices so they can help their communities in whichever way they can. There are many factors within our DCPS schools that do not address disciplinary action in the correct way, which negatively affects the behaviors of students. This may cause students to be put out of school, be expelled, or in general, just limit their involvement in school. This is a mistake that simply increases the prison to school pipeline and does not improve the attitude or actions of students. There is an immediate necessity to invest more in schools, whether through increasing counselors or support staff, mental health staff for students, to ensure that they are cared for and well taken care of. Within United Leaders for Freedom's campaign goals, we believe peer-to-peer mentors can have a positive impact on youth behavior as they aim to keep them focused and grounded in their academic endeavors. Another one of our solutions is Zen spaces, which would allow students to have a space where they can relax and decrease their stress from their academic workday, or even personal circumstances that they may be experiencing at home. This can improve not only student behavior, but also their outlook on their own life as well. A positive mindset, which is very necessary, especially in these times, to ensure the well-being of students. Thank you so much for your time.
Thank you. Savannah?
Hi, my name is Savannah Moss. I'm a licensed graduate professional counselor and national certified counselor here in Washington, D.C. I have the pleasure of being a part of Mary Center's school-based mental health program, serving Tubman Elementary in Columbia Heights. Today, I'm asking the council to ensure investment in the school-based behavioral expansion program through the Department of Behavioral Health. My own personal experience as a therapist working in a Title I school informs this request. Specifically, our schools are more than just places to learn academic material. They shape the emotional, social, and psychological development of children. As we continue to face years of unprecedented times, the mental health needs of students have become more visible and more urgent than ever before. School-based mental health services are a lifeline to DC families. They allow for accessible and consistent mental health therapy for students. Here in DC, students face systemic challenges related to poverty, housing instability, substance use, and community violence. For many, especially those from marginalized communities, this may be the only mental health care they can access due to barriers like cost, transportation, and insurance coverage. For example, there are less options for Medicaid-insured patients, which creates long wait lists, but because Mary Center sees Medicaid-insured clients, students are more quickly able to access these services. In my 1 year at Tubman Elementary, I have helped support children being ripped from their homes, losing loved ones due to incarceration and gun violence, being victims of physical and sexual abuse, navigating parental divorce and separation, witnessing domestic violence, and the list continues to grow daily. I have held up to 25 individual and group therapy sessions weekly, and for a 7-hour school day, that is an immense number of therapy sessions, and yet it is still not close to enough. I cannot help all the students who need my services due to the lack of mental health funding and support, coupled with unrealistic expectations about what one clinician alone is capable of. For example, it is unrealistic to expect one clinician to provide tiers 1, 2, and 3 services, provide walk-in sessions, support crises, enroll families in insurance, provide individual, group, and family therapy, assist in case management, support with medication management, and psychoeducate staff, all in a 7-hour school day. SBMH services are not optional. They are essential to the well-being of DCPS. Equitable access to mental health care must be treated with the same urgency as access to education. Students are telling us what they need, not always in words, but in behavior, attendance, and outcomes. It is our responsibility to listen, learn, and act in the best interest of our community. Thank you for the opportunity to testify, and I welcome any questions.
Thanks, Savannah. And I will have some questions for you. Courtney? Oh, Courtney's not here. Candace Ricks?
Okay. Good morning, and thank you, Chairperson Henderson and members of the Committee of Health. My name is Candace Ricks, and I am a school-based mental health therapist with Mary Center. In my current post, I have the unique and rewarding task of providing mental health care for the youth and families at Coolidge High School. Many of the young people that I'm privileged to support have high levels of adverse childhood experiences, or ACEs, that impair their ability to engage meaningfully within the school community. In addition, many youth are still processing their experience of the COVID-19 pandemic that resulted in the Surgeon General declaring a state of emergency as reports of depression, anxiety, and suicidality rose. I'm reminded of my work with a ninth grader who mirrors the youth that DC is most concerned about. He was referred for complications with grief, focus, and substance use, and his history of complex trauma and caregiver fatigue led to truancy and involvement with the carceral system. Despite this, I was able to act as a bridge for this student and connect him to services, including psychiatry and advocates for justice and education. While he was incarcerated, I continued to provide mental health support for he and the family, and upon reintegration, I partnered with school staff, his probation officer, and his family to advocate for his well-being and the repair of critical relational ruptures. Although his story does not have a perfect ending, he is, however, expressive about his desire to live and achieve his goals. I have many more stories about the resilience of DC youth who are seeking support toward a thriving life. From the overachievers who are healing from the experience of community violence, to the migrant youth who are struggling to adjust to the school environment, to the young people who are desperately wanting to work to improve their economic realities as they transition out of high school. The school behavioral health expansion funding allowed Mary Center's team to broaden and deepen our impact in schools, balancing Tier 3 therapeutic billable services with Tier 2 and Tier 1 non-billable universal and preventative services. My ask today is that we establish a minimum SBBH community-based grant at no less than $129,000 per school-based clinician, while maintaining, with inflationary adjustments, the current funding of $18,854,522 for the SBBH expansion program. I note that the proposed fiscal year 2026 budget has a cut of $2.3 million to SBBH programming. At this time, we're not sure about the impact of this cut. However, we know that even if the cut is to the expansion program, the minimum grant amount of $129K can still be achieved without restoring funding. While maintaining the 18.8 million would be beneficial to more schools, even with 16.5 million, the minimum grant amount can be raised to support schools already partnered with hired CBO clinicians and allow for additional growth of clinicians. Setting a higher minimum grant amount allows for more flexibilities for CBOs to meet the students that needs of the students that we work with on a day-to-day basis without significant billing pressures that the current funding model places on CBOs. Thank you for the opportunity to share, and I look forward to more dialogue.
Thank you. Laura Patton.
Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to testify today. My name is Laura Patton, and I'm a clinical supervisor of school-based mental health at Mary Center. Mary Center has been providing school-based mental health services since 2012 and is a member of the Strengthening Families Coalition. In my 6 years with Mary Center school-based program, I've worked 4 years as a school-based clinician and the last 2 years as a clinical supervisor. The council support of the SBBH expansion program has allowed me to personally serve many DC youth and families over the years, and it's really exciting to be here today to thank you for your continued efforts. This is important work, and we have much left to do. Via the school-based School Behavioral Health Expansion Grant, therapists engage in billable and non-billable services in schools, connecting students and families to services at Mary Center and beyond. Today, I'll share an example of the successes and challenges present in balancing this work. An elementary student was referred to school-based clinician with acute symptoms of anxiety. As symptoms intensified, this student began needing support beyond the weekly therapy sessions, often requiring daily check-in sessions and frequent crisis support. When it became clear that the student's symptoms were causing significant challenges across settings, the clinician took further steps, referring to and consulting with a psychiatrist, connecting the parents to their own therapist to manage symptoms at home, and coaching teachers to support clients' engagement in classes. The clinician also met regularly with school administrators to support the addition of a 504 plan. As a result, this student is now back in school daily with supports in place that allow them to thrive. While this story illustrates how school-based mental health services create a much-needed bridge, it also presented challenges for the clinician. During the months that this student's symptoms were most acute, the clinician's time was consumed with the non-billable work described above. As a result, their billable encounters dropped an average of 5 to 8 sessions per week for multiple weeks. This put them well below the weekly target of sessions needed to satisfy the rigorous billing requirements to financially sustain this program. In my experience, both as a clinician and a supervisor, these are the type of situations that feel impossible. When a need for non-billable support arises, billable services suffer, and clinicians often feel they have to choose between the non-billable work that families and schools urgently need and ensuring their billable targets are met. Over the years, I've seen that many clinicians leave this work not because they don't enjoy it, but because this conflict can make it feel unsustainable. I ask that the Council continue their critical support of DC youth and families by setting a minimum grant for the SBBH expansion program of $129,000 for those schools with a hired clinician in place. A higher grant amount would remove some of the billing pressures and offer more flexibility to clinicians to meet the needs of students, regardless of ability to bill. More flexibility would reduce burnout among clinicians and allow them to stay in this work longer term, which leads to deeper integration in schools, more consistent support for youth and families, and greater retention of excellent clinicians. Thank you for the opportunity to testify. I'm happy to answer questions.
Thank you. And thank you to this panel of witnesses. I feel like we've got the sort of both sides of the work, one from parents who are testifying about how important school-based mental health has been to their young people. And I appreciate all of you who shared your personal stories, especially Ms. Richardson. I'm so glad that your son is doing well. And then also to now hear from some of the therapists who are participating in the program. And so I want to focus my questions this round on the team from Mary Center, if you all can rejoin on camera. I'll start with Ms. Mass. Savannah, you in your testimony was sort of listing out all the variety of things that you are responsible for doing.
Yes.
In addition to individual and group sessions, right? So helping folks in terms of the Medicaid, addressing the non-billable pieces, et cetera. And you remarked, all of this is not what one clinician can do alone. My impression, and this could be different across from DCPS to public charter schools, is that there are usually other behavioral health staff supports at a school so that it's not all on the person who is the CBO clinician from DBH. Is that not what's happening at your location? Are you the only one?
We do have,
Or let me ask it in a different way. Are there other psychologists, et cetera, who are on staff, but their caseload is only special education?
yes, so we do have a few social workers, but they specifically deal with children who have IEPs, and I do not. And we do have school counselors, but they are not licensed therapists by any means. So I deal with the bulk of all of the long-term therapy requests, whether that's family therapy, individual, or group services. Sometimes students will start with the social workers, and then the social worker realizes they need more long-term therapy, and that's when they come to me. And right now, I'm seeing about 17 children. I see most of them 2, sometimes 3 times a week because of the acuity of the case, and I have about 10 on my wait list. Our productivity for a week is 20, and on average, I see about 25, and I'm still not, meeting the requirements of what all these kids need. So I am the only licensed professional counselor that can provide this sort of service, which is child-centered play therapy.
Got it. Okay. So it's a very specific type because I think we looked it up. And so, Tubman has a number of social workers, they have a number of counselors, but in terms of the group therapy piece, this definitely makes sense. Ms. Ricks, I'll ask the same question. Savannah is sort of working on an elementary school level. What does the staffing look like at Coolidge or on a high school level rather in terms of additional supports?
Yeah, at Coolidge, and I think at the high school level in general, it is similar where We have social workers, we have the school counselors that typically tend to focus on the academic piece. The school psychologist focuses on more of the testing piece. And then I'm the person in the building who is going to provide that longer term care, regardless, even with families, right? Maybe there may need to be some family sessions. I'm also able to connect the youth to services at Mary Center. So for example, if there's someone who needs support with substance use, we also have a family social worker that I have access to so that I can be able to make sure that they get resources for housing and such. So it just gives me the opportunity to provide the longer, deeper care and then connect them as well to wraparound services because I'm a part of a larger network.
Got it. Okay. Ms. Patton, there was a testimony earlier today that you might have been in the room sort of listening for, or you might not have, but from DC Appleseed, they said that a CBO would need to do at least $33,000 in billing to be viable, but that on most they're doing an average of 13,000 because the needs are disparate, right? There might be, but the school is really, really in need of services that are non-billable, but you need to do this sort of billing. Can you speak a little bit to some of that tension since as you serve as sort of the clinical manager of this work?
Yes. Yeah. Thank you for that question. It really varies across schools. In my experience, getting the opportunity to be in different schools, some schools have a smaller wellness team, that is to say less social workers or counselors on staff who may be exclusively seeing clients with IEPs, students with IEPs. We see generally students in the gen ed population. And so some schools may really need us to focus on that tier 3 individual family group therapy. Other schools may have a more robust wellness team, and they do have counselors who can provide some short-term counseling. And they may really need us to work on those tier 1 and 2 non-billable, universal and preventative services like parent workshops, classroom interventions, professional development training for teachers, teacher consultation hours. So it really varies across school settings. And I didn't get to see that testimony, but would agree that it's really difficult to meet billable targets to make our program financially sustainable for the agencies that we work under. I know that some CBOs have had to shutter their programs. Mary Center has been fortunate and invested in our program, but we face a lot of pressure to earn our keep and meet our billable targets while still responding to the needs of the schools in those tier 1 and 2 activities.
Yeah, I mean, it's kind of interesting kind of hearing you speak. And I think Candace, you even kind of alluded to this as well, right? This tension in terms of how you spend your time, knowing that you have this kind of looming target / goal that you need to reach on the other side. In some ways, it's very comparable to friends of mine who work in private legal practice, which is not what you want in a mental health setting, particularly in a school, right? Where you're thinking about this number as opposed to being able to just think about whatever your students might need. But we'll ask some questions about, I guess, the future of this program and what the vision is next week. But thank you so much for all of you for being here. Thank you to the PAVE leaders for being here as well. If you could submit your testimony for the record, if you haven't done so already, that would be really great. All right, we're going to go to the next panel. Hillary Kaser, Mark Labota, Bridget Hall, Nadia Goldmeritz, Sanaya Evans, Zainab Dembele, Ayanna Federo, and Janice Speaks McNeil. Again, you have to affirmatively accept our invitation to become a panelist. Okay, Hillary's not here, so I see Mark, so we'll go with Mark.
Thanks. Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Labota. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for district residents with mental illnesses, substance use disorders, or both, including the 35,000 district residents our 35-member organizations serve annually. The mayor's proposed FY26 budget for the Department of Behavioral Health undermines behavioral health crisis response and places additional strain on an already underperforming provider network. Proposed reduction of CHAMPS and CRT funding, elimination of the court urgent care clinic, and proposed new limits on community support services should be reversed. My testimony will focus on these issues, even while changing federal policy priorities threaten further disruption to health services. Reduced funding for CHAMPS and CRT and elimination of the court urgent care clinic take away resources that address behavioral health crisis as it happens. CRT is unequipped to replace lost CHAMPS capacity, and schools already ask school-based clinicians to attempt to de-escalate crises before CHAMPS is called. CRT and school behavioral health services also face cuts in the mayor's proposed budget. Cutting CHAMPS in the budget is an egregious error, and the funding needs to be restored. Eliminating funding for the court urgent care clinic is even less justified this year than it was already unjustified when it was proposed last year. The clinic offers embedded access to urgent behavioral health care in a place that emotional distress is a daily occurrence. The council reversed the cut last year, and it should do so again this year. DBH has shared that the $11.3 million reduction in MHRS local-only services will be achieved by reducing community support authorizations to 100 units per 180 days. 40 units is an hour, so 100 units per 180 days results in less than 1 hour of care being available per week for people assessed to have severe and persistent mental illness. This population faces multiple health conditions, housing issues, aging-related issues, and has extremely limited, if any, family or other support systems almost all the time. A medical appointment or assistance with a benefits application that requires going to a Social Security office might each take 2 hours. That would be all of the care available for an entire month. This will not work. Since 100 units per 180 days is clearly below the level of need for almost all DBH consumers, DBH risks running an operational deficit in FY26 if it actually authorizes supplemental units to meet need. Or the council risks endorsing a plan that has a most likely outcome of allowing consumers not to receive the care that they are known to need. The council should restore the $11.3 million to allow community support to continue to operate at 200 units per 180 days, subject to supplemental unit request as needed. I thank you for the opportunity to testify today. I look forward to answering any questions you might have.
Thank you. Bridget?
Good morning. Can you hear me?
Yes.
Okay, good morning. Yes, I'm sorry. Good morning, Councilperson Henderson. I thank you again for the opportunity to speak to you about a very important agency that supports my child care center. My name is Bridget Hall. I am the executive director of Big Mama's Children's Center, a center that has been servicing the Ward 8 community for the past 42 years. We are nationally accredited, and we serve 100% subsidized children of the district. And my ask is to have continued fundings for this initiative. So the continued support and reoccurring funds of the 3.2 million are very vital to the ongoing services and supports of our children and teachers in our program. We have, since the pandemic, have been experiencing a high quantity of children with special needs, with social emotional difficulties. And being though our teachers are credentialed or degree holders, we're not specialized in behavior services and things of the such. So our clinician from the Healthy Futures program is very, very important to us, and she helps the teachers be able to facilitate lesson plans to fidelity to children with social, emotional, or difficult behaviors. She helps with support services with the parents, recognizing or helping be able to willingly accept help for their children and be able to navigate through the process of receiving support services for difficult behaviors with their children or social emotional behaviors. Just a whole referring process period. And I beg that this $3.2 million is still going to stay in place. And so it will be able to help them preserve and or be able to hire more creative clinicians and support services. I thank you for this opportunity, and please still help us out. I appreciate you.
Thank you, Ms. Hall. And I recognize that you might not be able to stay for questions, so I want to say thank you for being here and for your continued advocacy on this program.
I'm here if you need me.
Okay.
Thank you.
All right.
Thank you.
Nadia?
Good afternoon, Chair Henderson, and thank you so much for this opportunity to testify. I'm Nadia Goldmeritz. I'm a Ward 4 resident, a public school parent, and executive director of the Young Women's Project, which builds the leadership and power of DC young people so they could educate their peers and improve their rights and opportunities. Our youth work as educators, as advocates and system rebuilders. And in the last year, we hired and trained 251 young people from 30 DC charter and public schools. And we have 120 on the ground right now, educating youth, collecting data, connecting them to counselors and clinics. I am here today, and I have a couple of young people joining me in a little bit, but I'm here today to testify and ask the committee to include $150,000 in the DBH budget to 2026 budget to support the school-based behavioral health student peer educator pilot, known as the youth pilot. And that half of that funding be allocated to support stipends for the young people. We are grateful to the committee for writing this into legislation in 2024. We have been the recipient for 2 years for this grant. In that time, we trained more than 220 young people who reached 11,000 of their peers and connected 4,000 to clinicians and counselors. We're asking for half as this program was funded at a level of $325,000 the previous 2 years. We are asking for half of that in light of this challenging budget year. So for the remainder of my testimony, the last minute, I want to highlight a couple of reasons why this work is so important. And first of all, as many have said, the issues of mental health continue to be urgent challenges for young people who report 31% report in a YWP survey of 1,000 that they are experiencing depression, 13% have thought about suicide, 75% are super stressed. The peer educators who work on this project reach young people that adults can't reach. 30% of young people said they would rather talk to a youth about suicide or depression than an adult. That's significant. Also, peer educators are able to fill gaps in school-based mental health. We still don't have a comprehensive curricula. They're able to collect data. I included that in my testimony. And they're able to work side by side with principals and teachers to inform them and connect them to young people. So thank you so much for considering our request, and I'm happy to answer any questions.
Thank you. Sanaya? Okay. We'll go to Ayanna.
Okay. Good morning, council members. I'm Ayanna Federo, an Ward 5 resident and junior at School Without Walls High School. Since 2023, I've advocated for mental health and youth justice with the Young Women's Project. We appreciate your support for the DBH school-based peer-to-peer program. Today, I am testifying to highlight the urgent need for stronger mental health resources in schools and to ask that the committee include $150,000 in the DBH FY 2026 budget to support the school-based behavioral health student P2P pilot, with at least half of that funding allocated to student peer educator stipends. Now more than ever, youth need part-time work opportunities, and $75,000 would be enough to cover 75 youth staff who will educate peers through school-based training and social media, collect data, connect youth to services, and advocate for their peers. Mental health and wellness are important to me because I've seen how stress affects students like me. Balancing schoolwork and expectations often causes burnout. Personally, I've had sleepless nights and trouble focusing in class due to stress. Some of my friends feel the same, but don't know where to turn for help. At school, the mental health staff are helpful, but their outreach is strained. Through Young Women's Project, I've learned how to advocate for better mental health support and share resources with others. Instead of doing a newsletter like I was going to do before, my friend and I are now focusing on posting mental health content on our Instagram pages. We're using social media to reach other students with wellness tips, resource info, and reminders that they're not alone. We hope to connect with school counselors and DBH partners to make sure our content is accurate and helpful. While my school attempts to address mental health, there is so much to improve on. Teachers see stress but may not provide adequate support. For instance, students needing help are often referred to counselors, but follow-up is lacking. After-school programs like mindfulness workshops are poorly advertised, leaving students unsupported. Um, Students just want more one-on-one check-ins and regular talks to emphasize the need for accessible and integrated resources. One major problem is school mental health teams' lack of adequate staffing. Counselors have a lot of responsibilities and often don't have the time to do mental health counseling with students, which is what many students need. So I recommend hiring more mental health professionals in schools to meet the ideal student to counselor ratio, including social workers and psychologists. Funds should train teachers to recognize and support students with mental health. And all in all, I just asked for $175,000 in our budget. So thank you for your time and attention to this critical issue. I hope you will consider these recommendations and prioritize funding for mental health support in schools. Together, we can ensure every student has the resources they need to thrive.
All right. Thank you. Janice? All right. Tracy German.
Hi, good morning, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to address the council today. My name is Tracy German, and I am the Director of Student Support Services at Academy of Hope Adult Public Charter School. I'm here to testify about the importance of sustained and enhanced funding for the school-based behavioral health program. For nearly 40 years, Academy of Hope has provided high-quality education and workforce training to adult learners across the district. We operate 2 campuses in Ward 5 and Ward 8 and serve more than 1,000 adult learners annually. In addition to instruction, we provide holistic support services because we recognize that adult learners often face complex barriers such as poverty, trauma, mental illness, and substance use that impact their ability to succeed in school. As a proud participant of the school-based mental health program, Academy of Hope saw firsthand the value of this investment. For over a year, we had a meaningful partnership with Catholic Charities, which allowed us to have an on-site clinician supporting the emotional and behavioral needs of our learners. That partnership was deeply impactful. Our learners had direct access to counseling services, crisis intervention, and a trusted clinician embedded in the school community. Unfortunately, the partnership ended unexpectedly mid-year due to the promotion of our assigned clinician and other undisclosed factors. Despite our efforts to maintain continuity, I was informed that it was unlikely we would be assigned a new clinician this school year. Months later, we are still waiting to learn what a new partnership might look like. Many of the community mental health agencies we refer our learners to are experiencing long wait lists and high staff turnover, which creates service gaps and delays in care. Having an in-house clinician is vital. It ensures continuity of care and allows our learners to build a therapeutic relationship within the context of a strong, supportive school community. This consistency can be the difference between a learner persisting in their education or disengaging due to unmet mental health needs. Our adult learners are navigating real and persistent mental health challenges. Many are survivors of trauma, living with anxiety, depression, and substance use disorders while balancing school, work, and family responsibilities. The loss of a dedicated mental health support has left a visible gap in our wraparound services. While we serve adults, their mental health wellness is just as vital to educational success as it is for youth. I urge the council to enhance funding for the school-based behavioral health program in FY26. Community-based organizations must be able to hire and retain qualified clinicians at competitive rates to ensure consistent high-quality care. Adults serving charter schools like Academy of Hope should not be left in limbo due to workforce shortages and limited capacities among CBOs. Every adult learner deserves access to mental health resources that can help them persist in their education, heal from past trauma, and build a better future for themselves and their families. We hope you'll prioritize this funding and ensure the infrastructure exists to make these partnerships sustainable. Thank you for your time and consideration, and I'm happy to answer any questions.
Thank you. Thank you to this panel of witnesses for your testimony. Mr. Labota, if you still with us, I wanted to ask you some questions in terms of maybe your understanding or what might have been communicated from DBH with regard to the proposed reduction for mental health and rehab services, MHRS. And what you're hearing from providers in terms of their concerns about that proposed decrease.
Yesterday, the Department of Behavioral Health had a meeting with provider organizations. We heard them tell us that the reason for the change to the MHRS local dollar funding was that they were going to reduce the number of units that were available per 180 days from the current 200 units per 180 days to 100 units per 180 days. As I described in my testimony, that's less than 1 hour of care per week for people with severe and persistent mental illness. When DBH made that announcement.
Mark, before you go forward, because we have some people who might be listening in who might not understand what that means. So can you say that in non-clinical layman's terms, what is the effect of going from the availability of 200 quote unquote units in 180 days to 100?
Yeah, so again, as I described in my testimony, this is basically saying you only get an hour per week of help. If you have a medical appointment that takes 2 hours this week, then we won't be able to see you next week. If you need to have someone accompany you to the Social Security office and help you with your benefits application, and that takes 2 hours, we won't be able to see you next week. It's cutting in half the amount of care that we provide to people who qualify for community support services. So it's a pretty drastic change. Based on the most recent statistics that we've seen from DBH, only 36% of consumers use 100 units or less in a 180-day period. So 64% of DBH's community support beneficiaries would see this cut affect their access to care.
Okay.
And you asked me how providers are responding.
Yeah.
When DBH made that announcement yesterday during the provider meeting, there was a literal gasp in the room. And we had to stop the conversation for about 30 seconds while people murmured about their immediate alarm. So this is not a trivial kind of reduction. DBH last year lowered the threshold from 600 units per 180 days to 200 units per 180 days, with an opportunity to request more support for people who needed more than 200 units. And that's already been incredibly cumbersome. I had providers who approached me after the meeting yesterday who said, this provider network isn't going to be here next year if those changes move forward.
Are there, I mean, and I'll certainly ask DBH this next week. There have been other changes that have been made to allowances and hours and otherwise, which in some cases were backed up by data, right? We saw some areas where some things were being misused, if you will, and it was resulting in higher increasing costs, but we don't actually think patients were being met or served by that. Again, changes that are sort of based in data around making these determinations. What would we look at here in terms of, like, was there anything offered as in, like, I don't know, 60% of our clients that were, or 60%, our data is showing that 60% of the billing is only for, 180 units, and therefore we feel comfortable with making this change?
No. So last year when DBH made the change to 200 units, you heard us not object. We said that we had concerns. We said that we needed to be thoughtful about the approach. We needed to make sure that the supplemental unit request process worked for people who needed more care. And unfortunately, it largely has not. But we understood, and the data supported, that I think it's something like 90% of consumers receive 200 units or less per 180 days. So we knew that utilization above 200 units per 180 days was significant and additional scrutiny was reasonable. 100 units per 180 days really is not supported by any of the evidence that we've seen, and raises real concerns that people just won't be able to get access to that care. The provider network, frankly, doesn't have the staffing to do all of the additional assessments that would be needed to do the paperwork to make the requests. And there's no mechanism to get paid for doing those assessments either with the frequency that would be required. So, this is a problem first for consumers who won't be getting the care that they need, but it's also just additional burden on the provider network that really can't be, we can't meet that lift.
Yeah, no, that definitely makes sense. I don't want to give anyone false hope that the council can just reverse this, because it is a result of it's about $11.3 million. That it was a decrease in this line, which is really hard to sort of just put back, if you will, if I'm sort of adding up all of the things that need to be quote unquote put back from this particular, just this agency, right? I haven't even gotten to DC Health yet, or healthcare finance.
Yeah, and Councilmember Henderson, I think you mentioned earlier that there needs to be continuing effort to address concerns around program integrity. I think that if we implement some of those recommendations, we can see the cost curve bent downward. And so part of this really does go back to making sure that DBH also is thinking about how to use the authorities that it has. And I don't know that they can save $11.3 million by using some of those other authorities. Maybe they can, and we should discuss with them how that would look. But the problem is, until those authorities are used, until those cost savings are achieved, then consumers are the ones who are going to suffer.
Yeah, no, and I mean consumers, but also on the other side, I did a talk for the DC Chamber a few weeks ago around what I think is a moment of disruption that we're having in our health system, but how do we also move forward? And one of the critiques or criticisms I have, even in sort of dealing in the government space, we sometimes forget that providers are businesses too. We assume that everyone is just going to buckle down out of the goodness and kindness of wanting to serve their clients, which many of our providers are certainly doing above and beyond what they are certainly being reimbursed for. But for us to expect someone to be able to build out their business model based on that goodwill is very difficult. And that was sort of some of the conversation from, the CBOs in terms of school-based behavioral health, right? Like, the model was established with this idea that I would be able to bill this large number that no one has ever hit, really, not no one, but for the most part, they've never been able to do it. And instead of us making adjustments based on conversations and data, we're just like, oh, y'all gonna make it work because you're a community-based organization and you care about the kids, which is not, I don't think is necessarily sustainable practice for us. Thank you for being.
And we see the losses. We see the financial losses that are accruing to the CBOs that are trying to do that work. And we see CBOs leaving as they're no longer able to do that work. And you've heard multiple people mention it today. I'm not telling you anything new, but just to reinforce. And we're also in a different interest rate environment. We're in a different inflationary environment. And so for some of our for-profit businesses, there are other uses that investors can put that money to that are going to generate a better return than continuing to be partners with DC government. So I don't think that we can make this up for nonprofits demanding more and more philanthropic support to subsidize DC government. And I don't think we can make this work for for-profits. Their investors are going to start investing in other business opportunities.
Well, thank you for being here. Ms. Goldmeritz, thank you for being here, and as well as having Ayanna with you, who is also always a very strong advocate on behalf of the work that her fellow peers are doing. You and I have met and we've discussed, and you've heard me say this before. I honestly believe that this grant, what we were trying to do with peer-to-peer, had real potential. And unfortunately, we haven't been able to fully realize that because of administrative implementation hurdles, not on the part of you as an organization, but on the part of the agency and getting the money out the door in a timely fashion. If we're talking about a student peer-to-peer program, it is unhelpful for the organization to receive that money in January in the middle of a school year. And I don't know. I've said it 6 different ways with DBH, expressing my frustration in this agency in terms of grants management being so poorly done. I don't know what else to say except for to maybe talk to the city administrator and the mayor directly about what's going on here. So, my struggle is that I can give you the money, I could put the money back in, but DBH won't spend it on time. And you're still struggling.
Well, I think in our case, Chair Henderson, we have been getting our grant allocations on time. I mean, we've, our staff at DBH in the accounting division has been really great and really responsive in our case. So I think there certainly are other administrative hurdles. But I think a lot of the hurdles have to do with the school-based infrastructure and how the counselors and clinicians are communicating and their capacity to engage with young people and incorporate young people into the work. So there certainly are administrative hurdles, but thankfully, money has not been one of them, and getting grant payments on time has not been one for us, even though I know other DBH grant recipients have been impacted by that. Yeah, and we're grateful to our contacts at DBH for looking out for that.
That's good to hear for in terms of yours, but it's still the timeliness piece in terms of your ability to ramp up, right?
Well, we
ideally
still
when you want to start in August, right? Or September at least.
September, and we did. We started in September. I mean, we've been the recipients for 2 years. During year number 1, we did not get the grant until March. We were still able to accomplish all of the goals of the grant, even though we only had 7 months. This year, we received payment starting in October. We had a full year of implementation so far. We go to September. We've already exceeded the goals and numbers, and we expect a banner year in terms of what our young people are able to accomplish. So I think this year was a really good example of what's possible. We are recommending that in light of the budget year, we are recommending that the funding that we receive half as well, that the RFP receive half as much. And in our case, we would be willing to bring foundation and other savings to support the rest of the funding that's needed.
Okay.
But I think we do have a full year of implementation, and I think this year really shows the potential of this pilot and what it's been able to accomplish. And as I said, Chair Henderson, young people are serving a different function than adults do in the schools, but they are desperately needed as part of the team because young people have such a strong preference for talking to other young people about mental health, for being educated by other young people. And so that would be sorely missed if we didn't at least have a placeholder for this work.
Okay. Thank you. I don't have any further questions for this panel. If you could provide your testimony for the record, that would be really great. We're going to move on to the next panel. Nadia Casey, Christy Matthews-Jones, Patrick Canavan, Bria Matthysse, Sarah Nason, Roselina Gulosil, Johanna Marino, Nicole Bellenus, and Gustav Band. Again, you have to affirmatively accept our invitation to become a panelist. A little box will pop up on your screen. Christy here. Okay. All right. Don't see, or I do see, nope, don't see Nadia Casey. And I don't see Christy or Patrick, but I see Bria when you're ready.
Morning, and thank you for the opportunity to testify today. My name is Bria Matthysse, and I currently serve as the clinical director for the CHAMPS program. CHAMPS has been serving the district since 2009 as a mobile crisis intervention and hospital prevention service for our youth. Over the past 7.5 years, I've served in every role within our program, from the front line direct care to now being in leadership, which gives me a full understanding of our operations, our challenges, and our impact in the community. Today, I'm here to express deep concern regarding the proposed financial decrease from $1.2 million to only $648,000 in the upcoming city budget. Many people assume that our primary role at CHAMPS is to transport children to the hospital when they're in crisis. In reality, CHAMPS functions more like a mobile emergency room, coming directly to the youth and their families in the community to provide real-time mental health support and prevent unnecessary hospitalizations. CHAMPS is a critical safety net for our DC youth in crisis. Over the past year alone, we have responded to 1,089 calls, providing clinical intervention for 873 of them. That's approximately 80%. The remaining 20% involves education, outreach, and helping families understand when and how to access our services. 78% of the in-person interventions that we provide resulted in stabilization in the community, allowing those youth to avoid hospitalization. We have achieved these outcomes with the staffing capacity capped at just 21 employees, including myself. To sustain this level of service, it cost approximately $1.23 million in salaries alone last year. All of our clinicians hold bachelor's and/or master's degree in social work, counseling, or allied related health fields. Most of our clinicians are licensed professionals, and all of them are trained specifically to work with youth in crisis. Despite our limited capacity, the demand for these services continue to grow. Reducing funding at this time would result in fewer available professionals that are trained to respond to youth in acute distress, longer response times and reduced service availability, increased reliance on FEMS and MPD to address behavioral health crises, which would be better handled by mental health clinicians trained to work with youth, less follow-up and community support, which increases long-term social and financial costs in the city. Youth crisis services are not optional, they're life-saving. Last year, for example, we served 348 youth experiencing suicidal ideation, 105 youth experiencing homicidal crisis, and 89 engaging in self-injurious behavior. I urge the council to not scale back its responsibility to protect our youth in the city. I would like to encourage that funding be restored to ensure that every young person in crisis has access to timely, compassionate, and professional care. Thank you.
Thank you. Sarah? Don't see Sarah. Roselina?
Good morning. Good morning, Chair Henderson and members of the Committee on Health. My name is Dr. Roselina Gulosil, and I am the Executive Director of Jubilee Jumpstart, a nonprofit childcare provider in Ward 1. I'm here to express strong support for the Healthy Futures program and urge the Council to maintain funding for it at no less than $3.4 million in the fiscal year 26 budget, with stable funding across the 4-year financial plan. We have partnered with Healthy Futures since 2017 and have had the immense privilege of working with Dr. Anais Lugo-Axman as our behavioral health consultant. Her consistent presence, visiting weekly, coaching staff, and partnering with families has built trust and transformed how we care for children. The value of Healthy Futures became especially clear after the pandemic. Many children returned to care with disrupted social-emotional development and limited tools to self-regulate. Young children don't have the language to say they are anxious or grieving. Instead, they may cry constantly, lash out, or shut down. This is where Healthy Future shines. Clinicians like Dr. Anais help teachers understand that behavior is communication, and they give us the strategies to respond with empathy and consistency. The impact goes beyond individual children. Our teachers are more confident, less stressed, and more likely to stay in the profession because they know they are not alone. As a director, I've also benefited from her insight in supporting my team, building strong relationships with families. Her work makes our center stronger, more inclusive, and more effective. Now, Dr. Anais is not only a clinician, she's also a Jubilee Jumpstart parent. That speaks volume about the trust and care she sees in our community and her commitment to early education. I want to emphasize that Healthy Future is not a luxury, it's a necessity. National studies show programs like this reduce teacher turnover and improve child outcomes. At our center, we have seen children grow in their initiative, ability to self-regulate, and other foundational skills for school readiness and lifelong success. The mayor's proposed FY26 budget reduces Healthy Futures funding to $3.2 million. That's $206,000 less than FY25, and represents an overall reduction of $1.5 billion since FY23. I urge the council to maintain stable investment in the Healthy Futures program, as this is essential to retaining expert clinicians, supporting our early learning workforce, and ensuring young children receive the behavioral health support they deserve. Thank you for your time and your continued support of early childhood mental health. I welcome any questions you may have.
Thank you. Johanna?
Good morning. Good morning. My name is Johanna Marino, and I serve as Education Manager at Jubilee Jumpstart, a nonprofit early childhood education center in Ward 1. I'm here today to urge the Council to fully fund the Healthy Futures program at no less than $3.4 million in the fiscal year 26, budget and to ensure stable funding in the district's 4-year financial plan. As a nonprofit, our budget is extremely limited. We cannot afford to hire mental health specialists on our own. So when we identify a child or family who might need extra support, we rely on Healthy Futures. Their consultants, as Anais, are essential to our work. This program helps us reduce classroom disruptions, lower stress for our teachers, and improve outcomes for our children. Let me share a story with you very quick. We have a young child who has a significantly speech delay. He was so frustrated that he began hitting himself. His mother was hesitating at the beginning to participate at the program with Healthy Futures, but once she understood the support that we could provide, she agreed. With Miss Anais' guidance, we saw a transformation. This child began using words to express himself. His tantrums and self-harming decreased. He could finally thrive in the classroom, and his mother finally felt hope. That's the impact of Healthy Futures. Without it, we and many other centers will be left without the tools that we need to support our children. We believe in a better future for our children, but we need all the support that we can use to be able to achieve that. Please protect this vital program. Our children, families, and educators are counting on it. Thank you for your time and commitment.
Thank you. Nicole?
Yes, greetings, Chairperson Henderson and members of the Committee on Health. I'm Nicole Bellenus, DC Long-Term Care Ombudsman Specialist with Legal Counsel for the Elderly. Thank you for the opportunity to provide this testimony on behalf of the approximately 525 district residents receiving long-term care services and supports in mental health community residence facilities. Our mission is to promote and help ensure the highest quality of life and quality of care for these individuals. I ask that my written testimony be included in the record. Today, I'd like to touch on 2 issues relative to the work of DBH on behalf of residents: CRF facility closures and reduced housing capacity for the adult mental health population. Our office has observed a sharp increase in the number of mental health community residence facilities, or CRFs, closing in the past several years. For example, in 2023, there were 8 CRF closures. In 2024, 5 CRFs closed. To date, in 2025, there have been 8 facility closures, with 5 more currently in the process of closing. This trend indicates that for residents with serious mental health diagnoses, access to safe and appropriate housing is declining. Unlike nursing homes and assisted living facilities, there's no uniform process for when a CRF closes. We have recommended to DBH that they create a CRF closure policy that outlines expectations, timelines, procedures, resources, and includes a plan for oversight and accountability. To adequately address this growing CRF capacity concern, our office recommends a thorough investigation into the reasons why these CRFs are closing. The reasons for closure that have been shared with our office have to do with financial sustainability. However, there could be additional and underlying issues such as staffing concerns, lack of support, or inadequate payment that could be contributing to this problem. A comprehensive investigation can identify priority issues to address in order to prevent unnecessary future closures. Currently, of the approximately 1,294 adults receiving services through DBH, there is a bed capacity in CRFs for just 525 people. With the additional closures scheduled for this summer, that total number of beds could decrease to 492. If the current trends continue, more residents who require specialized mental health care and housing will be displaced to the streets, homeless shelters, hospitals, and jails. These types of facilities cannot provide the ongoing specialized mental health care that these residents so desperately need, exacerbating public health and safety concerns for the district. With proposed cuts to the FY26 DBH budget, we're very concerned for what effects these cuts might have on residents and CRFs. Thank you for the opportunity to testify, and I'm happy to answer any questions you may have.
Thank you. Gustav?
There we go.
All right, there we go.
So my name is Gustav Band, and I'm a proud resident of Washington, D.C., a single father, and a member of the Jubilee Jumpstart. Before I share my story, I want the council to maintain the funding for Healthy Futures at least to $3.4 million on the fiscal year of 2026. This funding is a 4-year financial plan. I also want to say that it's critical that the Healthy Futures receives sufficient funding to retain all the early childhood behavioral health consultants, including their supervisors and the support staff. These professionals are the backbone of the early educators and children of our district, our community. My daughter Nia is almost 2 years old, and she's my world. I made the decision to build a better future for her. I was born here in the United States, but I was raised by my grandmother in Brazil, who was a Holocaust survivor. When I came back to the United States, I faced many challenges. Because of my accent, people assumed that I didn't know anything. So that bias made me hard for find a good job, access good services, even have a network of friends. When Nia was born underweight, I knew that I needed more support, and I wanted to give her a better future. That's when I found Jubilee Jumpstart. They recommended a Jubilee in my local library. Before Nia started as a toddler in the classroom, they gave me support, to access all the benefits that the city gives me. They helped me walk through custody matters and paperwork that I had to do. And she deserves a chance. She's now in the Jubilee Jumpstart, and she's growing. Thanks to the Healthy Futures program and the professionals like Miss Anais, I have learned attachment movements. I have learned activities that I can do at home. I got somebody that can guide me and help me out. She's grown. She has a social network. She's affectionate. She's always smiling. The girl is very good. My daughter is doing well. But this process is very fragile. Without the investment on this program, families like me have no ground. We're breaking the cycle of poverty, and one milestone at a time. Programs like this that are only 3.4 million really need to be supported by our communities. These children are the future of our country.
Thank you.
Thanks a lot for the opportunity.
Thank you. Thank you so much. All right. There were other people on this panel who weren't on before, but are now joining us. So let me go back really quickly. I'll go to Christy, if you're still here. Okay. All right. I'll go to Patrick Canavan. I see you on the screen, Dr. Canavan. Can't hear
Hi there.
you. Oh, there we go. All right.
Great. Thank you so much, Chairperson Henderson. I really appreciate the opportunity to speak with you today at this budget oversight hearing. I'm a resident of Ward 1. I'm a licensed clinical psychologist, and I've spent a good part of my career working in the District of Columbia government. And I've talked before at your hearings around the need for behavioral health urgent care as one aspect of the crisis system in care for residents of the district. It's all about trauma-informed. You've heard it a million times today in this hearing already, but it's all about trauma-informed care and how we can do better in the district. About 1/5 of all Americans suffer from mental illness. Only half of them receive any treatment across our behavioral health. It's too complicated often, and people often end up in the emergency room. My concern at this point with the kind of budget cuts that we're talking about is whether or not we have a system that is prepared for the sort of overflow into the emergency rooms that we will see as CRFs are closing, homelessness increases. Services are cut. We are going to have folks appear at the emergency room because currently that's the place where they believe that they can get care. I've talked with you about proposing an alternative, which is individuals who need either emergency or routine behavioral health services can be treated in a behavioral health urgent care center. This will decrease hospitalizations and ED visits, and has been shown in many states now to improve follow-up care and increase patient and staff satisfaction. We've talked with you previously about the empath model. This is the time for us to make some budget prioritization because we are facing so many very difficult challenges. I was at a meeting last week where Cedar Hill Hospital's CEO spoke about the use of the emergency department there and the extreme overuse of that, in particular by some people who maybe could have been treated at a lower level of care. I asked the question, but there was no data available last week about how many of those individuals had a primary psychiatric diagnosis who could have been treated elsewhere. What I can also tell you is, the department is making very difficult choices in a very difficult budget year. And I want to just applaud them for the success they've had in opening new model programs, such as the Stabilization Center, where people with both mental health and substance use disorder diagnoses can be treated. And then they get stabilized, and then they can be moved into the regular continuum of care. I see the trauma-informed behavioral health urgent care as a place to go that can support my neighbors in need of crisis behavioral care. I urge you in this difficult budget year to consider this model as integral to humane and trauma-informed responses to behavioral health crisis. I'm happy to answer any questions you might have.
Thank you. All right. Did Christy join us again? Or? No. Okay. All right. Well, thank you so much to this panel of witnesses. Roselina, Johanna, and Gustav, thank you for your testimony about the Healthy Futures program. I think it's actually a really good program in terms of the work that it is able to do and how it supports our early childhood centers, especially with early identification of and helping families throughout some issues. Ms. Matthysse, thank you so much for being here as well and speaking a little to the work that CHAMPS is able to do. I just want to ask a clarifying question. So you mentioned in your testimony that CHAMPS over the past year has done 1,089 calls, 873 interventions. In that numbers, I think it's important to underscore and clarify for folks that this is under technically reduced hours. So this is only in the daytime, right? Is that correct?
Yes, we currently operate in this building from 8 a.m. to 8 p.m.
Okay. And then, what is the relationship between you all and the crisis response team that traditionally only does adults, but now takes on the responsibility of doing kids from 8 p.m. to 8 a.m.?
So I think that CHAMPS and CRT over the past 2 years have been developing a pretty good relationship. So after 8 p.m., CRT takes on the youth calls, and then at 8 a.m. in the morning, they give us a call and then pass on any calls that they may have taken. And CHAMPS does all of the follow-up services to ensure that those children are connected to long-term services.
Okay, so you're still engaged with the folks that are coming in on the evening time. You're just not doing those particular runs.
Yes.
And I could ask the folks from CRT this next week, but in your evaluation of their notes, what are the numbers like of what they're seeing in the evening time?
I don't want to speak for CRT, but generally, the number of calls that they're passing over to us where they've actually conducted an intervention is maybe 3 to 5 calls a week, but that doesn't account for calls that they may have received that no longer required actual intervention after a short period of time.
Okay, got it. So I asked this question to Mark Labota, who was on before, in terms of sort of provider reaction, if you will, but did DBH give you all a heads up? And if so, what was the conversation around why they're choosing not to move forward with this youth intervention service?
I did not receive a heads up, and I actually don't have an answer to that question yet.
Okay, because it is not as though you are receiving 0 calls. So that means that there has to be some other plan in place that is going to account and offset for what you all are doing. And, you know, I'm looking at the budget and the community response team is seeing a decrease in their funding. So they're cutting you, they're cutting them, but the need still remains.
Correct.
Okay. All right. So we'll definitely follow up with DBH on this next week. Nicole, thank you for being here. And if you could provide your written testimony for the record, we can take a more fulsome look at some of those issues that are sort of arising in the long-term care space, or specifically for that population of adults. And we'll follow up there. Thank you all for being here. I don't have any further questions. Thank you. Okay, we got 2 panels left. We can make it. I have not taken a break. I'm also not drinking a lot of water. We're gonna make it. Okay, Cameron Green, United Leaders for Freedom. Kristen McKinney, United Leaders for Freedom. Cheyenne Blackman. John Hoagboom from Community Bridges. Anton Williams. Michaela Guthrie. And I think Christy was here, so perhaps she wants to join in with this panel. All right, we'll give a minute. Just a reminder for folks, you have to affirmatively accept our invitation to become a panelist. Okay, is Cameron here? Okay.
Yes.
All right, when you're ready.
Good morning, Councilmember Henderson and staff. My name is Cameron Green. I am a student at Roselina High School, and I want to talk about how important mental and behavioral health is in our schools. A lot of students are dealing with stress, anxiety, and problems at home. I believe schools need more counselors, more trusted adults we can talk to, and a better understanding of what's really going on with students. We don't act out because we want to. We act out because we need support. If schools work with mental health professionals and actually listen to students, we feel safer, do better, and have a real chance to grow. Thank you.
Thank you. Kristen?
Hi. Can you hear me?
Yes, ma'am, when you're ready.
Okay. Good morning, Councilmember Henderson and staff. My name is Kristen McKinney, and I attend Dunbar High School. I'm also a member of United Leaders for Freedom, an organization that empowers youth to use their voice and help their community. Today, I want to talk about how mental health and behavior are connected, and how students like me are affected by the lack of support in schools. A lot of schools are struggling with things like stress, anxiety, and trauma, things that don't always show on the outside. Sometimes it comes out in behaviors like acting out, not participating, or we just stop showing up to school. But the truth is, some of us don't have a safe space in school to calm us down. Some of us don't have someone to talk to who understands, and the rest of us just simply don't know how to cope. As of right now, we don't have enough mental health resources. Counselors are stretched thin, and some of us don't get the chance to talk to them at all. We need more than just one-on-one therapy sessions. We need a whole school approach. One thing that could really help is peer-to-peer mentoring. Sometimes it's easier to talk to another student who gets what you're going through. If trained right, we could support each other and create stronger community where students feel less alone. Another idea is Zen spaces. a quiet room in schools where students can go to breathe, reset, and take a break when things are getting overwhelming. It's not about avoiding class. It's about helping students and stay in school and manage what they're feeling in a healthy way. Sometimes 5 minutes of peace can keep a student in class instead of being written up or sent home. I think we can fund peer-to-peer mentoring in Zen spaces through grants, public-private partnerships, insurance reimbursements, and reallocating existing budgets. Support can also come from community fundraisers, foundation grants, and donations for sustained funding. Mental health is just as important as academics. If we feel supported, we can learn better, behave better, and show up better for ourselves and our community. We don't need more punishment. We need more support. Peer-to-peer mentoring and Zen spaces are real solutions that can make a difference for students like me. Thank you for your time and ears, and please include students' voices in making decisions about our mental health. Thank you.
Thank you. Cheyenne? Not here. All right. John.
Good afternoon, Chairperson Henderson. My name is John Huggerboom, and I have the privilege of serving as President and CEO of Community Bridges since 2019 and been with the organization since 1994. Community Bridges has the honor of being the operator of the DC Stabilization Center located at 35K Mental Health Clinic since its inception in October of 2023. Across my 3-decade journey as a CBI employee, I've witnessed firsthand the transformative power of what can happen when stakeholders come together to find common solution to a community-wide problem. That is exactly what happened when the DC Stabilization Center was created. Thanks to the unwavering support of Council, Mayor Bowser, Dr. Bazran and her incredible team at DBH partnered with FEMS, Department of Health, and CBI to transition that concept of a 24/7 no wrong door substance use crisis facility into a reality, which we now know as the DC Stabilization Center. Since opening in October of 2023, the DC Stabilization Center has seen over 10,000 admissions and, as originally intended, has provided the community and FEMS with an alternative to medical emergency rooms while also creating a safe place where patients and their families are welcome and treated with dignity and respect by peer support specialists and cared for by medical practitioners and registered nurses. Developed to address the in-the-moment substance use crisis and reduce the risk of fatal overdose and other substance use-related trauma, now with the support of DBH continuing, we are moving quicker into a new phase of enhanced services where we are reconnecting our patients with primary care and medications for chronic health conditions such as diabetes, hypertension, enhanced withdrawal management protocols, and providing direct treatment and bridge scripting for individuals who have an active or new mental health diagnosis. With our community partners, such as Unity Healthcare, Federal City, and RAP, we are continuously increasing efforts to connect our patients with the care they need and working with those same partners to help those who are continuing to struggle with complex behavioral health issues. While there is no easy answers or fix-all solution for fighting addiction, we believe that the efforts put forth by DBH, such as the DC Stabilization Center, have had a positive impact on the community and by offering crucial crisis-based services. Recognizing the growing financial constraints faced by the district, we ask that you continue to support those initiatives that DBH has championed and have made a difference in the lives of our patients and the families. Thank you again for allowing me to testify today.
Thank you. Anton? Okay. Michaela? Okay. All right. Well, thank you so much to this panel of witnesses. It's always especially great to hear from youth speaking about the importance of mental health in terms of the work that you all are doing. So thank you for being here. John, thank you for being here as well and providing testimony. The Stabilization Center has, at least the first existing one on K Street, has turned out to be a tremendous success story. You know, when we talk to FEMS and also even sort of talking to some of the hospitals, they talk about the ease for which the process has been made in terms of bringing patients over to the stabilization and then also getting them connected in terms of care. What challenges, if any, are you all anticipating or seeing going forward into this next year?
I think the thing that we're always mindful of are new trends in drug use, new things that hit the streets that are negatively impacting our patients, and then also throughput. We're always looking to make sure that our partners have availability and that there's services out there that are going to be able to treat folks on a continuing basis. Those are, what we're always looking at. And of course, funding is a big concern because, in order to have these types of services available to the community and treat your community as based upon their need, you need adequate funding to do that.
Yeah. All right. Well, thank you so much for being here. If you can make sure we have your written testimony for the record. We're going to go on to our final panel, which is hybrid for real because we have someone here who's here in person. So Ambrose Lane, Dr. Oke Inya, Dr. Kevin Fields, Chris Thomas, Michael Henson, Thomas Blanton, and Ray Savoy. Okay. Mr. Lane, I see you. Good to see you.
Good to see you too, council member, and I am testifying to you from my hospital room, even though the background is a little bit different.
Yeah, I was surprised to see your name on the witness list, but I'm glad you're in positive spirits.
Thank you. This is a very important issue to me, and I thought that I got 5 minutes and not 3 minutes.
Sorry, everybody got 3 minutes. Nice try. We've been here since 9. Nice try. 3 minutes.
Okay, fair enough. Let me first lift up the testimony of my fellow Ward 7 neighbors and the testimony of John Hogaboom, who does great work with CBI and the Stabilization Center. Take a moment to think about the men in your life that you hold dear. Once the person comes to mind, ask yourself these questions. Have they experienced any health issues in their lifetime? If so, what kind of care were they able to access based on their social economic status? If they were not able to receive adequate care, what were the barriers that made it difficult to assess it? As the month of May ends, June now becomes the expectancy of Men's Health Month. This nationwide health initiative and the city of Washington, D.C. have a shared commonality. The health status of men calls for attention. The Health Alliance Network advocates for a renewed focus on the health of men, particularly Black men. Washington, D.C. has been made the subject of social science journals and various news outlets as an example of exacerbated health outcomes. The District of Columbia has approximately 700,000 residents, and 46.4 of those residents identify as Black. On the other hand, the city has the largest life expectancy gap between Black and white populations in the United States. A study conducted by Benjamins et al. On mortality in the 30 most populous cities in the United States found that the racial disparities of Washington, D.C. were highest among all cities. Another study by Hashmain et al. Found that the overall mortality rate of the white population in D.C. has decreased since the year 2000, while the mortality rate of the Black population in D.C. has increased since 2012. This has caused health disparities between the Black and white populations in the city to worsen over the past 2 decades. The question at hand is, how did the district get to this point? To understand the multifaceted answer, we need to look at the risk factors that continue to affect the lives, specifically of Black men with the District of Columbia. So that testimony, council member, is part of an article that was written by myself and Michaela Guthrie, who sends her regards. She could not appear today, but that's going to be appearing in many newspapers over the next month. If the mayor is serious and if the council is serious and the city is serious, DBH and DC Health is serious about addressing the health conditions of DC residents, they have to focus on Black men's health. They represent the largest piece whether or not you're talking about incarceration, whether or not you're talking about cancer, whether or not you're talking about diabetes and chronic disease, whether or not you're talking about incarceration, whether or not you're talking about homelessness, Black men comprise the biggest chunk of health disparities in the District of Columbia. And we are saying that the council and maybe even the Opioid Abatement Commission, which you are a member of, needs to allocate money either for an Office of Men's Health or allocate money to provide research and outreach grants to reach Black men where they are so that we can begin to solve the problem of the major health crisis in Washington, D.C.
Thank you so much for your testimony. Dr. Inya?
Yes, good afternoon. I am Dr. OK Enya. I serve as chairman of the Men's Health and Wellness Committee under Me and Men Vote, a national initiative advancing civic engagement among Black men. I'm also a Ward 8 resident and a proud father of a 19-month-old son. As someone who has the privilege to have access to a Black male psychologist on a regular basis, I know firsthand the benefits of culturally humble mental health support. I want to pay this type of support forward. I commend the DC Department of Behavioral Health for its leadership in expanding community-based prevention, recovery, and mental health support, from school-based support to the community response team. DBH is laying the foundation for more resilient individuals and families. Still, across DC, and especially among Black men, the gaps persist. Less than 30% of Black men with mental health needs actually receive treatment. DC continues to lead the nation in Black male mortality that is related to suicide, substance use, and chronic stress-related conditions. The economic cost of untreated behavioral health needs among men is staggering, both in healthcare spending and workforce productivity. That's why I'm urging the council and DBH to support the establishment of a DC Office of Men's Health that works in partnership with the Department of Behavioral Health. This office could coordinate culturally grounded, trauma-informed behavioral health work for men and boys, partner with DBH's prevention programs to tailor messaging and access for fathers, returning citizens, and youth, and also integrate disaggregated data on men's behavioral health into DC's broader health equity strategy, as well as building cross-agency bridges between behavioral health, education, public safety, and employment. Thank you for your time, and I look forward to your questions.
Thank you. Dr. Fields? Okay, I don't think Dr. Fields is here. Chris Thomas?
Yes, good afternoon. Chris Thomas on the board for Million Man Vote. I come to the council today for this hearing to speak more about these issues. I'm directly affected and see this on a daily and weekly basis from the middle schools through also the high schools in the District of Columbia. Like it was first said from some of my other colleagues that just came before me, dealing with now the increase in homelessness from 18 to 24, dealing with the increase in suicides from 18 to 24. This is not a issue that would even be brought about. This is something that's a necessity, and it's something that's mandatory that needs to be talked about in the situation we're at right now. Where we've been disenfranchised, marginalized on all of these issues that are going on right now. In the district, we've been seeing the rates increase right now, very alarming, but with actually having a physical place where these men can come to and they can get the community outreach, and we can bring them in so that they're now getting the services on a weekly basis, brick and mortar, something that they can see and they can feel and they can touch. That is something that other people just said prior to me, but it's something that is very necessary because, again, on the different councils and the different committees that I'm in, I see this just driving around our neighborhoods with drop dropping off food and stuff. This is stuff where they talk to you, but everything doesn't always make the news. It doesn't always make social media, but men are crying out, and they're crying out at an alarming rate. And that's why, like I just said, with all of these different things, that these numbers just keep increasing, and it's happened directly in front of us in the nation's capital. So I come to y'all today to really put out that this is something that needs to be put on the forefront. We're the last to speak, but it's some of the first things that need to be talked about, to where we can start to save more of our culture and more of our young men. Our young men need this from starting in the schools, like the young lady just said, starting at Dunbar and going up into our ages right now. So when I come today, I'm representing a lot of the people who are, unfortunately, they're scared and they're frustrated, and it's hard for them to be vulnerable and vent and tell y'all of the issues that they're facing, not just in their house, but when they leave their house. So thank you again for my time. I'm Chris Thomas.
Thank you, Chris. Michael?
Good afternoon, Chairman Henderson and members of the committee. My name is Michael Pierre Henson of Michael Pierre Henson LLC and a member of the Million Man Vote. I am here to co-sign the previous testimony and statistics laid out by Chairperson Ambrose Lane Jr. I have read the statistics and agree with the alarming amount of information presented here today. I am an advocate for the Men's Health Initiative that we are proposing. I worked diligently for the last 25 years in the field of substance abuse and mental health, as well as an internship for 2 years at one of DC's elementary schools. 18 years of my substance use disorder employment was in 3 of DC's most largest medically assisted treatment programs. The amazing positive treatment behavior was astounding. I witnessed the decline of the Black community as a result of illicit substance use and abuse, as well as the mental health decline across Washington, D.C. I am currently instrumental in facilitating a substance abuse focus group in Ward 8. I'm a volunteer at a substance abuse recovery program. I am a volunteer speaker and organizer with other community leaders and organizations. In each of the endeavors that I am a part of, I work with members of each group who is suffering as survivors without a clear understanding that they have the power to thrive. They suffer as a direct result from lack of knowledge concerning their surroundings, their behaviors, their environment, their rights to live as normal members of the community, because of the limited amount of education they have due to the continual negative experiences that exist in their environment. With support from experienced, dedicated, and well-trained stakeholders in their communities, the potential to survive is overturned to those who can and will thrive. In the years of working with these members of those communities, I see desire, ambition, hope, the real need to be dedicated, spiritual strength, intestinal fortitude, and a strong sense to change a bad situation to a promising future. The only tool that I have ever used in order to witness and experience this phenomenon is conversation. I use my history as a welfare project raised young man who overcame the negative statistics to grow out of and into the man that I am today. I listen to and call them on the negative behavior without judgment and causing them no harm. They accept what I share with them with open arms and open minds. They are taught the value of being empowered, enlightened, and understanding that they are indeed the most important people on the planet, individually and collectively. Given half a chance, we can create a new generation guided by an experienced generation of leaders from their own community. Thank you for listening.
Thank you. Mr. Blinn. Oh, you gotta hit the button in front of you to turn on your mic. There you go.
Hello. Thank you very much. Thank you, Chairman. Good afternoon. I am Thomas Blanton, a resident of Ward 4 and a member of Million Man Vote. But I really am here because when I lived in Ward 5, I had tremendous neighbors. Like today, my brother, Robert Brannum, a member of the DC Fire Department, leaned over me on the steps of my front porch and asked if I was in danger to myself or anyone in my home. When I answered the question, no, he said, well, all right, we won't have any problems. Recently, I was told that 80% of the Black men who live in the district who are confronted with police are asked this question, but many of them will give the wrong answer. thus changing their lives forever. I am here today on the 40th anniversary of my wife by marriage, as opposed to being there, showing you how important this hearing is. With brothers, a Million Man Vote, and others who realize and know that the answer to this question shouldn't make a difference in people's lives. The district has created a system to address health needs of those in crisis, but it is under-resourced and understaffed. All too often, brothers with a need related to drinking, homelessness, and other serious health problems are pushed into the criminal justice system. This system should be there. These systems should be there to help the brother in need, a hand up as the officers did on my front steps, and taken back into the house where he can be given treatment. I support the Million Man Vote prayer planks and plea for the Office of Men's Health. I support having funds available to provide medical, especially mental health services for Black men and boys, because it is needed. I cannot tell you anything about this situation that you don't already know, and I've definitely been impressed with your grasp of the department and the needs in our community. You're not expecting facts and figures from me or other testimony that you haven't heard. So what are you waiting for? What is the district council waiting for? The political winds that blow your way that say give Black men and boys a chance to live a valued life in our hometown. Political winds grew quickly past when George Floyd was killed. Those winds are gone now, and the realities of our lives did not change. The conditions that produced George Floyd still exist, and we live with them in DC and in our homes. Please take a stand now. Look into the eyes of Black men and boys in our lives and ask them if they are a threat to themselves or to anyone in their home. Be ready to lift them up in the Office of Men's Health that can provide us with solutions that are responsive to the legacy of needs and that exists in our community today. You may be surprised as to the lives you may save. Thank you.
Thank you. And finally, Ray Savoy. Okay, I don't think we have Mr. Savoy with us. Okay. All right, just making sure that we didn't have any remaining folks before I get into this last question. Thank you to this panel of witnesses for being here. Some of your faces are familiar, especially on this particular topic. Since you all were sort of speaking about the same thing, let me just ask this, and then I'll let anyone who wants to speak on this is, what is the hope in terms of gaining from having a specific office? Is it research? Is it programming? What is it? Because some of the things that you all have raised around specific concerns with regard to Black men and health equity, we have an entire Office of Health Equity. Why couldn't this be a part of their work? Why do you need a separate office with a director, staff, X, Y, or Z? Is that not duplicative in nature? And could this not be accomplished through DC Health?
Thank you for the question, Council Member. As you know, I served on the Commission of Health Equity, so I'm very familiar with the Office of Health Equity and Dr. Arno. But this is a little bit different. If you look at every category, whether or not you're talking about criminal justice, whether or not you're talking about youth incarceration, whether or not you're talking about education, whether or not you're talking about chronic disease, whether or not you're talking about opioid and substance use addiction, all of these things, the majority of the population that affects these issues are Black men. Now, if the Office of Health Equity they have to recognize it because some of this is in their health equity report.
Yeah, it's in
But
their own data. So
it is in their own data, but not all of it is in their data. Okay, so you would think that they would be able to create programs, particularly programs that have outreach, research, and as you said, robust research, outreach, and programming. That's what is needed. It doesn't, we think that it should come under the Department of Health, but we're not committed to just that. We're committed to an action that focuses on Black men's health and the plight of Black men, because it's not just health and chronic disease, it's also social determinants. When we talk about homelessness, we're talking about Black men. So whatever office provides the focus of the city that can garner support from DBH, from DC Health, and from all other agencies on the plight of Black men and boys, then it can happen anywhere. It doesn't have to happen on DC Health. But the point is we need that focus, because if we don't have that focus, we cannot solve the health problems of the District of Columbia. We can't. More than half of all the disparities, Black men are at the bottom. And if you go down further, Black boys suffer the same things. They suffer the highest juvenile incarceration rates. They suffer the highest amount of abuse, according to the Criminal Justice Coordinating Council. So a 17-year-old who experiences these things at 17, in 5 years, experiences them at 22. And they're a grown man that is experiencing the same things. It is a continuum from teenage years into adulthood for Black men. And that's why there needs to be that kind of focus. And if it can't be under the Office of Health Equity or under DC Health, we are saying that at the very least, the council or maybe the Commission on Opioid Abatement should provide grants and loans to organizations to do outreach and research. So it doesn't have to come out of the mayor's budget. It can come out of the Opioid Abatement Commission money. I'm just saying the focus needs to be there. And I know, Councilmember Henderson, you are a member of the Commission on Opioid Abatement Commission. So there are several possibilities. It could be in a supplemental budget. We could ask other committees to give $500,000 from McDuffie's committee, from Charles Allen's committee. All they have to do is give $500,000, and we need $2.25 million to be able to do the proper outreach and organizing Black men to take care of their own health. We all know that Black men go to the primary care doctor the least of all of us, the least. So even a message to get Black men into their primary care doctor makes a difference. So that's why we're not wedded to the fact that it has to come under DC Health. We just think that Ayanna and I know her, and she's very community oriented, and I think that it's appropriate that it come under DC Health. But if it doesn't come under DC Health, it still has to happen.
Okay. Well, thank you for that. Ambrose, okay, you asked Kenyon for $500,000 or Charles Allen for $500,000.
I'm doing that right now. I'm doing it right now.
Budget. And it is not to diminish one program or another otherwise, but we're really having to have this question in terms of priority, right? And one of the things that had been discussed in terms of council members is like, don't start any new programs this year, right? Go with what we got. And frankly, if you've been listening to some of the testimony, I've got a lot and this is just DBH. This is day one, right? In terms of what we're trying to sort of figure out here. But no, seriously, I appreciate your advocacy and your continued attention and for all of the witnesses for being here. Mr. Blanton, don't you blame missing your wedding anniversary on us. But you know what? You're done before 1, and I hope you're taking your wife out to somewhere very, very lovely. Congratulations.
Let me come out of one more personal experience.
Yes.
You guys remember the lemon law?
The what?
Lemon law.
The limb of the law?
Lemon law.
Lemon law. Sorry.
It created in the district, it spawned the Consumer Claims Arbitration Board.
Mhm.
That was my first job in the district, 1985. Expertise, focus, and things come at a certain time. You know, this issue with men is over and late, you know, but things come at a certain time, and people develop the expertise and the sensitivity to deal with the problem. You know, if we can push this back during our time, that's our job. That's why we're here. That's why I'm here. You know, I'm 73 years old. You know, it is our time to deal with this problem.
Right. Well, you have the last word. Thank you so much for being here. I want to thank all of the witnesses who spoke today. If anyone was unable to speak at today's public hearing, the public record will remain open until Friday, June 13th. Written testimony can be submitted online on the council's hearing management system at dccouncil.gov/hearings. Our next meeting will be on Monday, June 2nd at 9 a.m. We're going to hold a roundtable very quickly, and we'll hear from the nominees to the newly created Board of Rehabilitative Therapies. Following that at 10 a.m., we will have part 2 of the budget hearing for the Department of Behavioral Health, featuring Dr. Barbara Bazaran and her team. So again, for folks who are trying to schedule and plan, 9 a.m., we're going to do nominees. 10 a.m., we will start with DBH government witnesses. There being no further business before the committee right now, this hearing on DBH is recessed until Monday morning at 10 a.m. The time is now 12:58 and we are recessed.
Thank you.
Thank you.